recording these programs so everybody will have an opportunity to watch it at a later date if they miss it. It doesn't count the same, but it does provide you some training from that. Okay, so this where did I get this? Well, I didn't just dream this up. If you go to the National Registry website, nremt.org, and when you get to that website, are y'all look? Can you see everything? Okay.
I see about three-quarters of it. It's cut off over
Oh,
towards the
sorry,
right.
sorry. Let me get that off there. I'll come back to it. There you go. Better.
Yes, sir.
When you
Thank
get
you.
to this, this is their homepage, and this right down here is your national certifications. Arkansas uses the NCCP, so that means we need to go to one of these. Today's class is for basics, but it is the same as the paramedic class. And we've got additional classes down the road for paramedics. So when I click on this recertification, it tells me what you need: 20 hours of the national component, 10 hours of the state component, and 10 hours of individual component for a total of 40 hours. So, the interesting part of this, if you scroll down right to the bottom of the national requirements, it says the 2016 NCCP EMT guide. There's one for advanced guide and there's one for paramedic. And by clicking there, you bring up this, which is the book, the competency guide, and then you have the lesson plans and objectives. So we're going to jump down there to those because the first thing we cover on our sheet of things to do today is the um, ventilation aspect. It's for 1 hour. It's going to be adult and pediatrics. And we're going to talk about these things. Here's our learning objectives. We're going to talk about adequate and inadequate breathing. All right. We're going to talk about respiratory distress and respiratory failure. And there's a difference. We're going to explain when to oxygenate and when to ventilate. And we're going to discuss the American Heart Association position on routine suctioning of the newborn. So these are the parts that we're going to go through here. Let me see. Save the bandwidth. There she is. We'll cut off my camera here. There you go. Welcome, Miss Foshi. Um, so the last objective is demonstrate. This is one you'll have to do with somebody else. Demonstrate back valve mask ventilation, proper depth and rate. And I think you all get that with your American Heart Association CPR. So let's dive into this lesson to talk about adequate and inadequate breathing. Okay, John, we'll start with you. Uh, Tell me what's adequate breathing? What do you see with adequate breathing?
Um, Hang on. Say again. I'm sorry. It was cutting in and out.
Yeah, it is still there. What is adequate breathing? If you have a patient and you report on your patient care report that they have adequate breathing, what is that? Describe what it would look like.
Describe what it would look like.
Yeah,
Say, there's no complication with them. Like if I'm looking at the patient and they're breathing with no distress, there's no obvious signs that they're having. You don't hear no wheezings, coughs, things of nature. They're talking to you with in regular voice, maybe answering questions, whatever the case may be. That's and I didn't see anything, or hear anything. I would say that's adequate breathing. The um, also if we were checking their, you know, O2
Yes.
level
Oh
percentage.
my.
I mean, I could be. That's how me just visualize it. That's
sure, sure. Somebody else had something to say? Okay. So adequate breathing. Todd, what would you add anything to that?
I had to find the unmute button.
Okay.
They have good color. Um, they're perfusing well, I guess you could tell by their color.
Sometimes they use the abbreviation in PCRs, PWD,
Pink one dry.
warm and dry. Absolutely. That's adequate breathing. They're perfusing, they have good mentation, they're conscious, they're alert. You know, when you walk through the door into the room where they're at, they will go squirrel. and know that you're there. And yeah, so that is adequate breathing. Now, on the flip side, Regina, can you help me out? What is inadequate breathing? What does that look like?
Can you hear me?
I can hear you.
Oh, inadequate breathing is when they're not pink and they're not warm and they're not dry and they're not breathing. They're a little blue and their chest is not going up and down, or they may be struggling a little bit, labored breathing, agonal respirations.
That's all good. All good. So they are exchanging what's called tidal volume. Oh
Yes.
my. What help me out here, Jamie? Tidal volume is about how much?
800 to 1200.
Yep, and they're finding out 800 to 1200. But when we get to the new 2021 AHA, which will be coming out in February, that's going to go down some. So they're saying somewhere between 5 and 800. So they're lightening up the load a little bit, because if we give too much air, it doesn't go into the lungs. It goes where? Anybody? Toss a
LA.
guess.
Stomach.
Yeah, into the stomach. So we got to have an adequate minute volume. Oh my gosh, why would we do minute volume? Well, that's the rate times the tidal volume. They got to have the right rate. Can they breathe too fast?
Yes.
Good.
Can they breathe too slow?
Yes, and it's not good either.
There you go. So we live in this narrow band. Now, for those folks of an advanced rating, they have to maintain a pH of 735, 745. They have to have a PCO2 of somewhere between 35 and 45, and their pulse oximetry should read at least, in your protocols, there's a number there,
92.
92 to 94. That works. So when they get below 94, maybe they need oxygen. If they get below 92, they may need oxygen. Is there any time you'd put oxygen on a patient if their SAT is above 94?
Yeah.
Yeah. And that would be when the patient is asking for it, and you're doing it there for more of a psychological treatment than for a physical one. Okay, so inadequate breathing requires immediate management, because if you take away our breath, we will die. Yeah, we will cease to perfuse. We will cease to do all those vital things that a squirrel gave us earlier about how, pink, warm, and dry, and that stuff. We'll cease that. So inadequate breathing requires the management with a positive pressure ventilation. Some of our COPD patients right now currently get what for their treatment? Say that again. You're down low.
Through my reason of knowing that as it, he gets oxygen and he takes medication every day.
Right. And sometimes they get put on CPAP, BiPAP, or some kind of PEEP, positive end expiratory pressure, to keep those velar sacs open. All right. So when we look at inadequate ventilation and inadequate breathing, we got to see if they're adequate tidal volume. You may have dealt with a patient that was trapped in a space and had something pressing on their chest. That would stop their tidal volume. You could do that in a car accident. You could also do that in a granary or in a pit if the dirt fell down on you. And there we go. Who is Galaxy 9?
That might be me.
Are you driving?
Yes. I'm
Good.
taking my mother to her doctor's appointment.
That's fine. And identify yourself.
Stacy Bixler. I don't know how to turn my.
Stacy.
I don't know how to turn.
Okay, I needed to know that so I could check in.
Yeah, I don't know how to turn my volume off so you don't hear me.
Hey, I have the power. I can do that.
Good, thank you.
And if I ask you a question, I'll unmute you. So, okay, listen up for questionings.
Thanks much, sir.
Well, I said I could. Huh. There it was. Okay, it's just running slow. Okay, so let me get that out of the way there. Okay, so adequate breathing doesn't require any positive pressure ventilation. So if they have a good rate, they have a good depth, and there's a combination, they will exchange oxygen down in the alveolar space. So adequate breathing versus inadequate breathing is really a visual game. It's something that you see when you first come into the room. It's something that you gather or glean from the doorway. You know, if you get there and you're going on a collapsed building and you come into the room where the patient is at and they've got a huge beam on their chest and they're blue and they are cool and clammy, they're probably not having adequate breathing. And that means we got to aggressively do that because we already said if you don't, these patients will die. Now then, um,
Bad day.
somebody had something to say?
Oh, sorry. I was saying they was having a bad day if they're all those things.
Yeah, John, they are having a bad day. Now, John, you started us out last time. Let's start with Todd. Let's look at this one, Todd. Respiratory distress versus respiratory failure. Can you give me respiratory distress?
They're just having they're not quite to the well, it's not as bad. Let's start there.
Okay. Can you have dyspnea without having distress?
Can you have what?
Dyspnea, difficulty in breathing.
Yes.
Yes, you can. And distress means you've stepped down from dyspnea to distressed. And then the next step would be failure. Now, if you can see your screen right there in the outline, it says respiratory conditions are what? Dynamic. What do they mean by dynamic?
They change.
Ever changing, ever changing. Never, ever, ever, under penalty of the Caduceus gods coming down and beating you over the head and shoulders with a star of life, say, my patient is stable. Because patients are never stable. If you're alive, you're always changing. Your breathing changes, your blood pressure changes, your pulse rate changes, your mentation changes, and we are dynamic beings. When we get stable, we're basically dead. I guess you could call the patient stable if they were dead, but that's not the same connotations. We say maybe the patient is within clinical norms. That would be mean the same thing. Okay, so with respiratory distress, it could be minor to full respiratory arrest. I mean, it fluctuates from one to the other. Squirrel was telling us about, was that your father-in-law that has respiratory problems?
It's a stepfather and all. He had
Stepfather. Okay.
OPD.
Yep.
It's real bad.
And
And I've
those are chronic.
yeah.
And we talk about chronic, we talk about long term. We all got them in our lexicons. We've all got patients that we go see routinely all the time. And you get the call and you go, oh, that's Mr. Smith or Mr. Jones, and he has COPD. So we're having a respiratory problem. It's a chronic situation, but it can be a chronic situation that has led to acute exacerbation. So you may have a chronic situation that now has gotten urgent. Now, a lot of times we run on those acute things. A kid, and I'm not just meaning they're cute because they're kids, but acute because that means sudden. Kid that has never had a problem eats a candy with a nut in it that he's allergic to. Now we're looking at an acute respiratory distress that could lead to respiratory failure. So, as these signs and symptoms change over the time, depending on the state of the patient's disease process, we may have to look at them and determine whether or not they are in respiratory distress or failure. One of the big kicker, Jamie, what about you? You know what the big kickover is from distress to failure? We've talked about it already a little bit. Did I lose everybody?
No, she may just be working with some patients and she's at work at the ER.
Oh, okay. I got a message from her. All right. She'll tell you about that one herself. So,
Yeah, baby delivered in the car.
yeah, that's what she sent that out to everybody. Okay, good. Let me see here. Who else is in here that I haven't hollered at, talked to? Hey, Regina,
Can I ask?
go ahead, John.
I'm drawing a blank when you was talking about the acute exacerbation. Exactly what was that again? I'm drawing a blank on that word.
Okay, well, what happens is they have the chronic problem, okay, and then suddenly they have a worsening of the situation, or it's gotten rapidly worse. So that's what they're
Oh,
talking about
Alrighty.
there.
okay.
Miss Re- Miss Regina, you there?
Yeah.
Okay. The
Do you
question
know
I
where
had
you're
for
going,
you:
sir?
what is the big thing that goes from respiratory distress to failure? There's one crucial event.
This walkway is going to just dig around here. You're going to go straight on down.
I
Nope,
can't.
straight. Okay, and then it's going to, you'll see the carpeting and the glass waiting rooms there.
Regina.
Go on.
Yeah, I can't
Right
hear,
around the corner,
hear her
there's an
talking.
elevator there.
Okay, I got it. Go ahead now.
What did you ask me, honey?
Okay, here we go. Respiratory distress to failure. There is
Mm-hmm.
one crucial thing that happens. What is that? And we've already
Well,
talked about it a little bit.
distress to failure is when you stopped breathing.
When we fail
Your drive is gone.
to perfuse,
Mm-hmm.
the patient that is blue is not in distress. They are in failure.
Yes.
And that means we need to gear up and get going quick, fast, and in a hurry. All right.
Mm-hmm.
Now, all right. Thank you, Regina. Appreciate that. Many patients have respiratory diseases and only need comfort care. That's that O2 that you put on just a little bit just to make them feel better. But we got to know exactly when to provide intervention. You know, if they were breathing less than 10 a minute, that would mean something that maybe we'd have to start bagging. If they breathed continually for 30 times a minute and they were not in oxygen debt, then they may need to be driven by ambu bag. And a lot of that is dependent on the patient's disease process. So we need to look at these patients and try to maintain that 92 to 94 SpO2 or a 35-45 end-tidal CO2. And you've got those devices that we can put on and use them because they measure quantitative and qualitative information. Okay. Now, in respiratory failure, it may be down in the little cellular bags down in the lungs. That would be the alveolar ventilation. And somebody, Todd, give me a disease that affects the alveolar area.
Would
Not the,
that be,
not, go ahead.
would it be COPD?
COPD, that's chronic obstructed. That's more of a tubular problem. Asthma is more of a
Asthma?
tubular problem. Asthma is a tubular problem because that's in the bronchi. You're getting close. You're heading in the right direction. We used to call it CHF. Now we just call it HF.
Congestive heart failure?
Yeah, which is just now heart failure. And that happens because the right side of the heart's not pumping out the blood. It's backing up into the superior and inferior, left side of the heart's not pumping blood. It's backing up into the aorta, into the pulmonary veins and then backs up in the alveolar sacs. And it causes the extravasation of the passage of fluid into the alveolar sacs, which causes them to be filled up. Now, that is an alveolar sac problem. Now, you mentioned COPD and you mentioned asthma. They are obstructive. They are not letting the air reach those alveolar sacs. And when those alveolar sacs don't have that air coming in COPD, a lot of times those little cluster of grape alveoluses will rupture and they will turn into one big floppy alveolus and they won't stay open. They'll collapse. They'll have that atelectasis. And as they collapse, that causes respiratory distress and can lead to respiratory failure from them trying to work at breathing for so long that they just wear themselves out. So when they have when they have alveolar ventilation as a decrease in excessive high pressure rate. So they're trying to breathe in, they're trying to breathe in, and they're working at it. They're working at it. This is going to be those people that, what kind of symptoms are you going to see with those?
They're going to be short of breath. They're going to be working to breathe. Their oxygen sats are going to be low. They could be pursed lip breathing, tripod setting.
There you go. Those were the ones I was looking for. Grunting, head bobbing, all of those are going to be seen. And
Audible wheezing.
audible wheezing. Yes, you walk in the room and you hear them wheezing, there's no doubt that they're in distress. And then if you look at their color and all the other stuff, that means they could be going into failure. Thank you very much. Um, these people are severely ill. You can imagine if it'd be just like trying to breathe with your head in a plastic bag. You can do it for a little while, but it won't work. So we got to recognize that transition from the respiratory disease to respiratory failure, and that's that mental condition change, confusion, loss of gag reflex. That's bad because that doesn't protect the airway, but it's good because it allows us to put in an advanced airway to protect that. Head bobbing, accessory muscles, grunting, nasal flaring, and of course the decrease in SpO2. All right, cyanosis, and then hypercarbia. So we've got some tools in our toolbox to work with this airway, correct?
Correct.
Thank you. And what kind of we the two we have as basics are the OPA and the NPA. Everybody loves the OPA, not so much the NPA. I don't know why that is, but they both have their place, and they both do assist in keeping what out of the airway.
Keeping the tongue from blocking it.
There you go. Thank you very much. And they are put in, and they keep the tongue from falling to the back. Now there's some indications for them, and there's some contraindications. Let's talk about the oral pharyngeal, or the OPA, first. It is indicated in patients with respiratory distress and failure, and they can have to be, not may be, but have to be unconscious and unresponsive, because one of the things that makes you have to remove an oral airway is the patient has a active
Gag reflex.
That reflex.
gag reflex. Yes. And you got to also worry about them when you have those traumatized patients that have broken teeth and recent oral surgery. They will not be able to take an OPA. But never fret. If we can't use an OPA, we can always revert to the NPA. Uh, Lots of different names for this thing. It's called a nasal trumpet in some places, nasal pharyngeal in other places. It basically is a red tube, and it needs to be lubricated with water soluble lubrication, that Kentucky jelly, KY jelly, and it is indicated in respiratory distress and failure. And there are some contraindications for the NPA. What would those be?
Facial trauma.
Yeah,
Skull fracture.
yep, very good. And why would you not want to put an NPA in somebody that had a skull fracture or facial trauma?
You'll pierce their brain.
You can go through the cribriform plate right in the back of the nose, and you can interject the nasopharyngeal airway right into the brain and oxygenate them that way. That would not be good. Now, more aggressive airway management is something that has it's kind of waning. You know, the Heart Association tells us if we can open the airway and maintain an airway and get adequate chest rise, that's the key word, adequate chest rise, then we should be able to go with that right there. In fact, they're telling advanced providers, do the least you have to do to maintain the airway. So that's the new wave that's coming. Well, how do we put a pediatric patient? Are pediatric patients different from adult patients?
They're very, very wiggly.
John, you're very, very right. How about anatomically, their airways?
Smaller.
Smaller airways. Good. Thank you, John. Let's see here. Okay.
I know it's hard. I have a 10-month, and it's hard to even suction theirs because they move all the time.
They do move all the time. All right. Miss Bixler, are you there? Stacy?
Yeah, I'm here, but I'm here.
Okay. Well, we were talking about
The
adult.
NPAs. Oh, the different
No, we're talking
anatomical.
about, anatomical position between adults and peds.
Uh huh. Everything's smaller. And it's you got to like with CPR, you can't press as hard. What else?
Airway.
The airway.
Yep.
Uh,
Think about the things above their shoulders.
You
That
got to
kind of
lift their
thing.
chin up to open their airway up.
Yeah. Their head is larger, so
Mm-hmm.
they need what behind their shoulders?
Some, uh, something raising their shoulders. Something raising their shoulders up or their head up to where they're opening up the airway.
Okay. Thank you very much. I'll take you off the spot.
Thank you.
All right. So let's see here. Jamie, can you talk right now? Boy, this thing is lagging here bad. I'm sorry, folks. Well, Regina, how about you? Are you with me?
I am.
You know about babies, right?
A
How
little
do
bit.
how do we have to position them? Because adults have these big tracheas that are rigid and hard. What does a pediatric patient have?
Well, they have a big head and a little airway, so you need to put a towel underneath their back of their shoulders to let their head fall open to put their airway in a neutral sniffing position.
Right. Now, are you an advanced EMT?
No, I'm a basic, and
But
I
you've got
have
a
my.
lot of experience, right?
Hmm.
So if I ask you what is the most narrow, what's the narrowest part of an adult's airway, you would say,
The narrowest part of the adult's airway,
yeah, it's those things that vibrate found in the
the
larynx.
vocal cords,
Yes, very good. But what's the narrowest part of a pediatric's airway?
the trachea.
Well, the cricoid membrane just below the larynx. So just below the larynx, you'll find a real narrowing area of the trachea, and that's why pediatric ET tubes do not have cuffs because that narrow area will wrap around them. So that's just for heads up, because a lot of times they'll say, well, somebody's aspirated and they've got it in their trachea. That's true, but it's probably at that cricoid pressure, and
Hmm.
that's one of the things that we deal with. Newborns, we need to put them in a sniffing position. If you imagine a rose in front of the nose, they jut their chin out. Don't um, do an excessive head tilt chin lift, because it's just like trying to drink through a McDonald's straw that you bend over. What happens?
It won't.
Yeah, it blocks up. It basically crimps the airway. And you can do that. And we have done that in the past with patients, pediatric patients. So thank you very much. So take a little special care with those, all right, as you deal with the pediatric patients. Um, Todd, if we've got somebody here, it's a pediatric patient, and maybe they've aspirated something or they're choking on something. How do we deal those patients?
We're going to remove the obstruction
Yep. If you see it, right?
if you can see it.
Yeah, because we don't go fishing for them. It just doesn't happen. Um,
They still use back blows.
we do back blows,
Yep.
and we also do chest thrusts. So we do both of them to make sure we clear that. And in pediatric infants, we try to invert them, so gravity helps us too there. All right. When they are old enough to stand up, then we use chest thrusts. When they get older, they've got armpit hair. Of course, then we do it just like adults, and we do an abdominal thrust. Okay, good deal. Good deal. Thank y'all. Y'all about to get the hang of this thing. We're going to be asking questions, moving in and out all day. So stay close, stay engaged. So, how about newborns? We're
Hey,
talking
question
about
on that.
those. Go ahead.
Um, we use gravity again, to help us on the newborns or your infants and stuff. And when it comes to like you just said, standing like your toddlers or a little more mature kids and all. And this could probably go for anybody, and so anybody can jump in and correct me if I'm wrong, but I still think gravity could work for us if we could get them bent over. Now, correct me if we shouldn't, but I would think if you could get within reason, kind of help that gravity help towards you, especially if they're on the smaller side. Or would I be wrong?
Uh, I wouldn't think you were wrong. I have seen people invert, 3, 4, 5 year olds, especially if the person doing the rescue attempt was large enough to lift them up. Uh, it wouldn't be following
Okay.
AHA's recommendations, but if it comes out, then hey, you're a hero. If it doesn't, then you didn't follow the guidelines, and you probably are in trouble.
Right. Okay. That's why I wanted to, I mean, I've seen it where it says, your age guidelines and stuff, but I'm just trying to think of, within reason and doing what we're taught to do, following the protocols, also things to help us and not necessarily work against us, and trying to, work a little smarter and not so much harder in a degree.
I understand,
But
and I agree. Um, so yes. Now let's talk about what Jamie had a while ago. Somebody delivered a baby in a car, and newborn care. That's this 5. This is the last little bit of this part we're going
And
to
let
do
me
here.
tell you, while we're talking about my baby in the
Sure.
vehicle,
Uh-huh.
23 years in EMS, I still have not delivered a baby, but I've been there twice right after the fact. There's something just really not fair about that.
Well, I tell you what, I will pray to the OBGYN gods, and maybe they'll send you a baby to catch.
All right, thank you.
I'm with there with her. I want to help too.
I guess I've been blessed in my 40 years. I guess I've delivered about 6. So from crowning all the way through. So Jamie, when the baby comes out, we used to teach you guys to aggressively suction the airway. Now,
Correct.
the American Association of Pediatric Doctors say what? What do they now say about suctioning the airway?
Well, I don't know. I mean, are they saying not to because it can cause a vagal response?
This
Because
is
I know
very
this
true.
one just popped out and it was crying and carrying on all by itself. I
Well,
mean,
that's what we got to look at, and what they look at is if you suction them, you may cause the baby to go into bradycardia
right.
through the vagal thing. So they're saying
Yes.
if they come out like yours, crying, vigorously crying, no distress in their
Hmm.
ventilations, you know,
Leave it be.
it's nature. Let nature take
Yep.
its course. And that makes me happy if nature's taking its course. It's only when they come out
Absolutely.
and they need assistance,
Hmm.
obstruction, maybe from meconium, maybe from, a mucus plug that they can't get out. It's very few of those. It's very few of those. You go back to pioneer days. You go back to the Indians. You go back to the cave people. They didn't
Hey,
have
do you
bub
mean to tell
suction.
me that they didn't have bulb suction thingies?
No, they didn't have bub suction thingies.
Are you serious? That's
Serious. Can you
craziness.
believe? Yeah. So by us getting more advanced, we are really trying to uh, use tools that really aren't needed. The more we get into medicine, the more we find out if we just let it run its course, maybe it would be better.
Absolutely.
I'm just thinking, especially
If it ain't broke, don't fix it.
if it ain't broke, don't fix it. But yeah, the guidelines, AHA guidelines say do not suction a newborn if it exhibits vigorous crying and respirations. I'm sure all of y'all have run on a choking baby call or a choking child call. And when you get on the scene, you hear aggressive crying out in the distance. And the first thing you say is, whew, they got an airway. And that's true. So you suction the newborn if they have respiratory compromise, distress. They're not pink. They're not, they're not going to be dry, but they're not warm. They're not pink. They're ashen. They're pale. Their respiratory rate is below, you know, slow. We may need to assist them. If they're bradycardic, we may need to assist them. So there you go. That is the biggest thing that comes out of this right here. So do we suction newborns? No. When the way I was taught, when the head presented, when it rotated to the left or the right, you aggressively started suctioning. You suction while the rest of the baby was still in the patient, still in the uterus, still in the birth canal. And boy, according to the American Academy of Pediatrics and Neonatal Surgeons, that's wrong. And I'll admit I was wrong all those times. All those that I helped deliver came out and did okay. I guess I didn't aggressively suction them too much. Uh, but yes, don't suction babies now unless they need it. And don't suction it while they're in the birth canal because you may stimulate them to take a breath in while they're still in the canal, which would cause them to be delayed in delivery. All right. Questions,
So when did that
comments?
change? Did that just change?
Yeah. The last year I taught 2 years ago was when it came out. I was teaching my paramedic students, and paramedic students now have all sorts of ways to get online with their phone, get online with their computer, and pull up new information. And while I'm teaching and trying to, do my sage on the stage and tell you all this and all that, they come up and found out that you wasn't supposed to suction. And
Yeah, because I've seen some of the changes, but I know as I was wrapping up when we were in the OB portion of our EMS class in school when I was becoming EMT, they still had us suctioning as the head popped out. That's what we were taught, So that's
how many eons ago was that?
That was 2018.
Probably about 2018 is when it changed.
Yeah, it sounds about something mentioned after that, not long after that, that we weren't going to be doing that anymore, supposedly. But I was going to ask, is that, when you hear the crying and all that, because you and Jamie can probably contest, and those that's been there on the deliveries or before or after the fact, they come out, but not all babies, necessarily probably cry first out. So would you, on the not suctioning, and I know this is common sense, but I'm asking it anyway. Is that going to be before or after you kind of spank their butt to get them to cry? Say if they come out without crying,
we don't spank their butt anymore either. We stimulate them, we rub them around, and they need to be dried because they're coming out of a wet environment. So you take a towel or as clean as stuff if you got and rub them around a little bit. And when you start rubbing them around, they don't like that.
Not to mention all the white waxy stuff.
True.
All that stuff needs to be cleaned off.
Well, the white waxy stuff cleaned off if you've got a warm environment, Jamie, because if you're in a cold environment, that waxy stuff holds the heat in.
True.
Okay. Well, that makes sense.
No slapping people, John.
I'm not. I was kind of saying it more as a tease and all. I know we don't necessarily slap them,
You just look at me. No slapping people, John.
You can slap people, just don't slap babies.
What'd you say, Regina?
I said you can slap people, just don't slap babies.
There you go. John, look at it this way. How would you like just to enter the world? The first thing you do is meet an EMT or a paramedic who is delivering you, and all of a sudden they slap you. That would give you PTSD right there.
I'd be like, hey, y'all, slap back. I'm a squirrel. Come on.
You just
Born
bite
though,
them and latch
had
on.
out. I wrapped my umbilical cord around my neck twice. I
You're
told him
lucky.
I wouldn't get to come out.
Yeah, you lucky just to be here.
Mm-hmm.
So, do we know the difference between adequate and inadequate breathing?
Yes, sir.
Oops,
Adequate
sorry.
breathing, air goes in, oxygen goes round and round, blood pumps through. Inadequate breathing, nothing comes in, nothing's pumping, nothing's going anywhere, you're dead.
Thank you, Regina. Very good. I think she summed that up pretty well, didn't she? And then respiratory distress and failure. You want to bring that to focus as sharply.
You're circling the drain, and then you're not.
You're circling the drain, then you're dead. Good job. That works for me too. All right, and let's see what else. There was one. When do you oxygenate a patient? There's numbers on this one.
92,
Below 92, give them some
and then
oxygen. Now, remember these COPD patients, these chronic lungers that have been breathing for a long period of time on very low O2 sats, they may have SpO2s low, but that may be normal for them. So be cautious with those patients.
I had a question on that, if you don't mind, real
John,
quick.
bring it on. I bet you I can find somebody that can answer that.
Well, in by all means, step in. Since I've been on the ambulance and learning a lot of this here, which I've been grateful for, on cases I've been on COPD or anybody that's had these in-home oxygens, depending on if they're the distilled water kind or so, purifying more of the air versus an actual O2 canister. When we assist them or give them O2 on our trucks, and like I said, anybody jump in, I've noticed that folks I've worked with has we possibly step down the O2 because our O2 on them trucks, especially if it's coming out of the tanks and they don't have it at home, is the pure oxygen. So we step it down a little bit because they're getting, I guess the best word is to say, more pure O2 than what they had on their machine. So now, is that still correct and stuff? I mean, is that okay? Because I do see the reasoning why we would do that a little bit, because you're going from, say, 4 or 5 liters at home on something distilled water and all. It's not per se O2 as it is on our O2 bottles or canisters. So sometimes we would step that down a little.
John,
Does that make sense?
it does make sense, but medical grade oxygen is medical grade oxygen. It should all be the same across the board. Concentrators does concentrate to the oxygen, and it should be medical grade, just like what we have on the truck. We might want
Concentrate distilled water.
the
Is
water
that
you're
what you think?
seeing. The water you're seeing is a humidifying that oxygen, so it's putting a little
Okay.
humidity in the air, because oxygen is
Okay.
very drying. It will cause nasal passages to crack. It'll cause them to bleed. So yeah, that'll work. Does that make
Okay.
most?
I go off on that. Yeah, it does. I go off on that, and so I was kind of probably misunderstood on some of those that had that oxygenators and gave the little moisture and stuff. So
Sure.
I just wanted to ask that. I didn't want to confuse nobody.
That's a good question, and it's a good entry level question that you need to know. Medical grade oxygen is medical grade oxygen. Now, is there non medical grade oxygen? Yeah, people that use oxoacetylene welding torches, the oxygen, the blue bottle they have, it in the green bottle that we have. And the difference is supposedly, according to the experts that work for these air gas companies and all these guys, that medical grade oxygen is filtered more. So it doesn't have impurities in it, where the stuff that you weld with might have impurities in it. All right.
Right.
But the bubbling in the water is just a humidifier to put a little moisture back in there, so it doesn't cause the nose to crack and dry out.
And that's what it was. But I honestly, on those machines, I truly was unaware if that was still medical oxygen.
Yes, sir. All right.
Stacy,
did you get your mother to the doctor? She must be still working.
Hey,
Hey.
I'm in Leslie headed to Conway.
Oh, okay.
So I'm going to be driving my whole class.
Okay, that'll be fine. I'll be checking in with you. I can mute and unmute you. I just
Okay,
wanted to
good
make sure
deal.
that you had we'll probably lose you going from Leslie down toward yeah, through some of
Maybe
those
so.
bottom ways headed into
Yeah.
Clinton. Watch that road construction at Clinton. It's a mess down there.
I know we had to go through there with the rig going to the ER.
Yeah. All
It's
right.
not fun with the lights on. All right. I'll
Drive
talk to
safe.
you when. Bye.
Bye bye. There she goes. All right. So, does anybody need to take a break right quick, or do y'all want to forge ahead? We are through with the respiratory section. Yay. The next thing we go into will be oxygenation. So, we're going to just keep going that way. The sooner we get moving, the sooner we can be done. This is supposed to be about a half an hour. So, this would end up somewhere around a 9:30. So, what is the pleasure of the class? It's your class, it ain't mine.
I'm good to keep going.
Roll on. Roll on. We'll do that. We'll roll on. Okay, I'm sharing my screen. You're going to see. There you go. This is what we're dealing with here. Half an hour here. And this is the way we're going to do it. Now, if we come up with something that has a link to pop out to, we'll pop out to it. If anybody wants to watch a video or something like that, we can do that. So we need to analyze the pathophysiology related to oxygen transport and metabolism. Oh my gosh, he's going to get off into that pathophysiology, right, Todd? Todd just loves it when I get into pathophys, don't you, bud?
Oh, yes.
Oh, yes. Well, we're going to get into some of that this time. And now we're going to talk about the AHA guidelines for oxygen therapy in post-cardiac arrest. ROSC and getting a patient back, and then how are we going to handle the oxygen therapy, and also in patients with ACS, that's acute coronary syndromes, and stroke patients. So we're going to look at those guidelines this time, and we're going to discuss the role of free radicals. Now, squirrel, that's not your neighbors. They may be radical, but they're not free radicals. And we're going to talk about how free radicals relate to oxygen therapy. All right. So if you have questions about any of this, stop us at any time. Okay. And looky there. There's a link right there. I'm going to get to that in just a minute. So the American Heart Association guidelines recommend that patients with acute coronary syndrome, ACS, or stroke not receive oxygen unless, had to throw that unless in there because some of them do. If they're SpO2, and that's the pulse oximetry, that little thing that clips on their fingers, if it reads less than 94 on room air, then you may need to give them some oxygen. That says if pulse oximetry is unreliable or not available, oxygen should be administered. And that's true. Never withhold oxygen from a patient that is requesting it. You could give them 1 liter. That would only take them from 24% up to about 28. So it wouldn't be a whole lot. If they complain of dyspnea, there's that big word. Dyspnea means what? Difficulty.
Breathing.
Thank you.
I couldn't find my unmute. Like, where's my unmute?
It's okay. It's okay. I appreciate you jumping in because that's what I need to know. Anyway, anytime you see the prefix, suffix, the suffix PNEA, that means breathing. PNEA means breathing. DYS is the prefix, and that is difficult. So it's basically dyspnea means difficult breathing. What can cause difficult breathing? You know,
A lot of things.
a lot of things. Weights on your chest. I had to stop for a minute because I taught this one time and got in trouble for saying something on your chest. So yeah, things on your chest, things that are maybe not a confined space where the oxygen content isn't above 16%. So let's go back just a minute. All right, Todd, here we go. Let's see how we did on this pathophys. How much oxygen is in room air?
I'm not sure I can tell you.
Take a deep breath. Okay, how much oxygen was in there?
Not much.
A Newton County answer would be enough. How much is in there? Enough. Well, what's enough? 21% is enough. All right. So if you breathe in 21%, it goes through your nose, down the pharynx, down the trachea, down the bronchos, out into the lungs, down to the velar sacs. Oxygen exchange takes place, and then you breathe out. When you breathe out,
15%.
Okay, I heard somebody say it. What is it?
Carbon dioxide.
15%, I think.
Yeah, you breathe out 15% oxygen and a whole lot more carbon dioxide to make it up to 21%. So you're only using 5% of the oxygen in one breath. But in a confined space, you should never go into a confined space. You should know this one, Todd, as a firefighter. If you got an oxygen sniffer, you never go into a confined space if there's less than 19% oxygen in there. So that's what we're looking at as far as the oxygen levels. If you breathe in 21%, you breathe out 15%. That's why there's enough air in your expired breath to do mouth to mouth to make it work. Now, don't give them oxygen unless they have complaints of dyspnea. And if they have signs and symptoms of shock or heart failure, then they need oxygen. That's that congested stuff that we talked about earlier. So what do we give out? What now? I think Jamie probably was, and Regina, you may be too. I'm not saying that y'all are old, but used to we taught EMTs. How much oxygen did you put on people?
15 liters on the breather every time.
That's it. That's it. Preached it,
High
sister.
flow.
High flow, everybody. FiO2, high flow, high flow, high flow, high flow, high flow. Guess what? That was the
Nope.
pendulum swinging that way. Now it's swinging back the other way. So now we do not use high flow oxygen. We only give them oxygen if they are dyspneic, if they have a SpO2 less than 94, or signs and symptoms of shock or heart failure. And then when we give them oxygen, it's basically 2 liters by nasal cannula.
Yes. Just enough.
Just enough. Just enough. We want them to have an SpO2 at 94 or above. We don't want to correct them all the way to 100% because COPD patients, if they're on high flow oxygen for a long period of time, can and will go into respiratory arrest. So try to titrate. Oh, that's a big word, titrate. What does that mean? In Newton County, Todd, that would be fiddle with the oxygen to maintain an SpO2 of 94. That's also Woodruff County. I'm from Woodruff County, and they would say you wouldn't say titrate over there. The good old boys over there would spit their skull on the ground and go, "What do you mean titrate, boy?" Okay, so yeah, so the effects of ventilation on venous return and cardiac output. Got a normal patient breathing in and out. All right, the chest is. Here's another pathophysiology question. How does breathing work, Todd? Blinker zone.
You're picking on me an awful lot.
I'm sorry. That's because I can't get to Jamie because she's on duty.
She's just sipping on her coffee right now. This would be a great time.
Sorry, I'm trying, guys.
Okay.
I'm at work.
Okay, Jamie, tell me this. How does the thoracic cavity work?
Well, it's actually the opposite of what you would think, because the diaphragm actually contracts when on the inhale. Is that correct?
You're right. And the ribs
Because
do what?
because I think you would automatically think that the contraction would be exhalation, but it's the opposite. It's inhalation. That diaphragm contracts, pulls down, pulls air in, and then you're. Do I have blood down there again too? Okay, sorry, we're still having baby issues.
Okay, go ahead. Go to take care of the baby. Come back to us later. So
well, baby's gone, but I'm here. I'm coming back and forth.
Okay,
but,
that's fine.
I mean, isn't that the gist of it?
Yes, the gist of it. The big question is, and this will be for John. Squirrel, answer me this one. Are the lungs attached to the chest wall?
Are the lungs attached to the chest wall? No.
Yeah, no. The lungs just basically hang inside this cavity. And as like Jamie said, the diaphragm pulls down, the ribs go up, the chest cavity makes a negative pressure. And if it gets a negative pressure, then the air goes through the nose down and the pressure equilibrates inside the chest. And that's how respirations happen. Then when it's in there, it changes its oxygen, and then we get this exhalation. And Regina, can you give me that exhalation? That diaphragm goes which way and the chest muscles goes which way, and what happens inside the chest?
I'm calling my mouth full.
I'm sorry.
It's okay.
We'll let you chew it up, and we'll go on. What now?
It relaxes, and then you breathe out.
Right. The ribs go down, the diaphragm comes up, and the pressure in the chest is a positive pressure, and it forces out. Inhalation is a active process. Active process means we're using muscles. Inhalation, active. Exhalation, passive. You've all seen the movie where the guy gets shot, or the arrow from the Indians go in the cowboy's chest, and he goes, oh, and he dies. But he always exhales, and why he exhales is because that's a passive process. Now, got to have that negative pressure. Problems with the chest, if you get a knife that goes into the chest and it has another hole for air to go in and out, what happens through that hole?
It puts pressure in the wrong spot and causes a lung to collapse.
It does. And it takes less pressure to go through the hole in the chest than it does to go down the trachea. So you may get sucking chest wound, you may get a pneumothorax, and then you also may get a tension pneumothorax, which is a deadly situation. Got the lungs in the thoracic cavity, and there's one more big organ in there. There's a couple of other little ones, but the other big organ in there is the heart. In Woodruff County, they'd say thumping gizzard, but that's true too. It hangs inside there between the lungs. So you got 3 lobes on the right side, 2 lobes on the left, the heart lying in the middle of it, and it all works together. So as the chest relaxes and the air rushes out, then the heart fills with blood. When you breathe in, the heart pumps that blood out, and that in itself can affect the blood ejection fraction from the left ventricle in 1 minute. Somebody have something to say?
Casey, I haven't heard you say blood goes in and out, or air goes in and out, blood goes round and round. Anything else is a bad thing.
It's a bad day when that happens. You're absolutely right, Jamie.
If there's one thing I took from paramedic school, right?
Yeah, that's it. We was going to get into that in the summary, but you're absolutely right. And since we're talking about the heart is a 4-chambered, 2-cycle pump. It's got atrium, it's got ventricles. On the right side of the heart, it receives blood from the low pressure system, the veins, the supra and inferior vena cava, goes into the right atrium. The right atrium then goes to the right ventricle, and the right ventricle pumps blood out through the pulmonary pulmonary arteries, out to the lungs, where it gets oxygenated. Then it comes back by the way of the pulmonary vein into the left atrium, from the left atrium to the left ventricle. Then it goes out through the aorta, throughout the body, down through arteries, arterioles, capillaries, and that's where the oxygen exchange takes place down at the cellular level, and then the loop comes back. Blood is a closed loop. Now, some of that fluid stays out, and that's in the interstitial, and that's a whole nother topic on another lecture. But with cardiac output, we're looking at stroke volume times the heart rate. We got to have, you said you got to be pink, warm, and dry. You got to have perfusion. But that perfusion also has to have oxygen in the blood. So if we have a problem in the lungs and it doesn't let our oxygen get on board our blood, we could have beautiful, perfect, wonderful cardiac output and still be in problems because we had respiratory distress or respiratory failure. So we got to remember stroke volume, amount of blood comes out of the left ventricles. If you read some studies on that, they say anywhere between 6 ounces to 12 ounces. And I don't get into all that. It doesn't bother me. I don't have a way of measuring it unless I'm transporting a patient from the hospital that's on a balloon balloon wedge pump, then I could probably tell that. But that negative pressure during inhalation allows venous blood to return to the right side of the heart. So when you exhale, blood flows into the heart. When you inhale, usually that's when the ventricles kick in and you get that lub dub. Now, we have to do artificial ventilations. And I'm going to click on this and y'all tell me if it comes up. It's coming. Do y'all see that? Can you?
Yes.
Okay. Death by what?
Hyperventilation.
Hyperventilation. Well, they're looking
Hyperventilation. Yeah.
else.
And then it says a common life-threatening problem during cardiopulmonary arrest or resuscitation. If you haven't read many of these professional articles, these research articles, it's good to look at them. And may I take just a moment here because research is in our thing we're supposed to talk about today. This is an article, and what you need to do is look at the what they're looking at here. This is a transitional research focused on the physiology of cardiopulmonary resuscitation. So they're looking at CPR by clinical observation. So they're not measuring here, but nothing but observation, consistent with hyperventilation by professional rescuers in out of hospital cardiac arrest. Who's professional rescuers in cardiac arrest?
Wouldn't that be your EMS?
Yeah, this one's right directed at us. And it's generated scientific hypothesis that could only ethically be tested in the animal laboratory. So they didn't do this on humans. They did it on animals and they checked them out. So you go down here, you read the conclusions. This is what you need to do when you're reading a science paper. See what their hypothesis is up here, okay? And their hypothesis examine uh, was to examine excessive ventilation rates during the performance of CPR by overzealous but well-meaning rescue personnel. Well, I'm glad they say we're overzealous and well-trained. That causes significant decrease in coronary perfusion pressure. Anybody taken CPR lately? What is coronary perfusion pressure? Bueller?
I'm drunk.
Bueller? Okay. Here it is. When you do compressions, you are squeezing the heart between the
Between the chest, between the lungs.
sternum and the backbone.
Oh, the sternum.
And every time that blood gets squeezed out, that is the coronary perfusion pressure. Okay?
Yep.
To keep the heart alive, it has to be a certain amount. Heart Association and the International Committee on Resuscitation have figured out it takes 4 to 5 compressions of hard, fast CPR to get the coronary perfusion pressure to the point that it will perfuse the heart and perfuse the lungs. 5 compressions. And that 5 compressions are 5 out of the 30 that we do for a patient. So if we lose 5 and we're doing 30, only 25 of our compressions are good, meeting adequate coronary perfusion pressure. Now, if you hyperventilate, you're pushing oxygen into where?
Besides the lungs, you mean? You mean
Yeah. Into that thoracic cavity. That thoracic cavity is a sealed container. We've already determined that a while ago. So if we put extra air in there, we overpressurize it. And what does that do to the venous return to the heart?
would it constrict?
Shuts it down. Shuts it down. So if you drop the blood coming into the heart, when you compress it, what happens? It drops the pressure out. Drop the preload, you get problems with the afterload. And that's what this is talking about. So their conclusion is this, and I'm going to highlight it here so maybe you can see it better. Can y'all see that, or do I need to make it bigger? It says, despite seemingly adequate training, professional rescuers consistently hyperventilate patients during the out-of-hospital CPR. Holy mackerel. I guess it may be something about our adrenaline being up there. What do you think, Regina? Do we get excited when somebody's in a full rest? Probably do. Most of us do. Have
I
I
have.
lost? Go ahead.
We can.
Okay. So, and we're well trained. That's good. And we're professionals, but we breathe too fast. And it says subsequent hemodynamic, that means uh, the blood, and survival rates in pigs, that's close as they can get to humans, men anyway, demonstrated that excessive ventilation rates significantly decrease the coronary perfusion pressure and survival rates. So, us hyperventilating the patient is basically doing what? Okay.
We're oxygenating. I mean, bad juju.
Yeah, we're killing the patients.
But last time I checked, we weren't resuscitating any animals
No,
per
but
se.
they're talking about this as being extrapolating into humans, and it does show up that way. Um, so, despite supplemental O2 to prevent hypocarbia, traditional research initiative demonstrates an inversely proportional relationship between intratracheal pressure and coronary perfusion pressure during CPR. They say additional education of CPR providers is urgently needed to reduce these newly identified and deadly consequences of hyperventilation during CPR. So let's go back up here. When was this done?
2004. They're a little behind on the looks of it.
They're not behind. We are.
Where's the? Oh, we are. Okay.
Yeah. So what they're saying, and the new CPR that's coming out is going to discuss this in some length, and we need to slow our breathing down. We need to stop hyperventilation as of now. Stop it quick, fast, in a hurry. Do not hyperventilate patients. It doesn't do them any good. In fact, it is detrimental. So increasing that intrathoracic pressure impedes venous return of blood to the right side of the heart. That is the preload. Anybody that's worked on a fire department that has taken a fire truck out and thrown a hard suction line into a pond that had a whole lot of moss and grass in it, and you started pumping water from the pond, and then all of a sudden that suction line got covered up, that filter down at the bottom got covered up with all the junk that was in the pond. What happens to the outflow of the water?
Less water because
It
poor
goes
suction.
down. It goes down. So, that's the same thing with the human. If you put in too much air into the thoracic cavity, you impede the blood coming out of the left side, and that's a bad thing. And also because the left side from the aorta at rest, that's where the heart muscle gets its blood, and that is the coronary perfusion that they're talking about. So, excessive ventilation rates during positive pressure ventilation decreases cardiac output. That's
Is
bad
there a
juju.
percentage on this?
Go ahead.
Is there like a percentage on this? Like how often is this actually happening compared to our actual cases that we've, as EMS as a whole, has gone on? Because in a lot of cases, you're, at least in the few that I've had to do myself, I can't speak for others, it either has working or you're still working on them by the time you get to the hospital. So what's the number rate of this actually happening when we're over hyperventilating, or I just lost my word now, but
Look at ROSC. Let's just look at ROSC.
okay.
Nationwide, ROSC right now is about 9% if we do adequate
Okay.
CPR. If we do adequate CPR, less ventilations, doing it the way that the researchers say we should, places
Mm.
like Phoenix Fire, places like Seattle, Washington, There's some more places around El Paso, Texas, Dallas, Houston. They're getting a ROSC percentage of somewhere around 10 to 20%. Still not great, but would you rather have 9% resuscitation or 20% resuscitation? And we're
20%.
seeing those numbers go up as we see people hyperventilating them going down.
Yes. Okay.
So numbers, I don't have numbers for you, but if you get out there and you go to the American Heart Association and look at their website and research pre-hospital ROS numbers and just look at some papers out there that's been published, it's proven that we are hyperventilating patients to death. The same thing that when I first became a paramedic, we sodium bicarb people to death. They would routinely get 3 amps of sodium bicarb, followed by 3 amps of sodium bicarb every 5 minutes of the cardiac arrest because we had to get their blood pH back to normal. And what were we doing?
Right.
We were fixing the blood, but the blood, once the pH got fixed, didn't pick up the oxygen. So therefore, we were killing them with all the bicarb. And we're doing it again now with hyperventilation. And how do we know hyperventilation is doing that? Because we have research. Somebody said, why are you bagging one breath every second? That's too fast. And,
Right.
we get excited, and you're trying to give a breath every time they make a compression. And I've seen it. Todd, you've seen it. I'm sure Regina's seen it, and everybody on the call has seen those people aggressively breathe. They're saying now one breath every 5 to 6 seconds. And the ventilator has got to be trained and got to be focused on not hyperventilating the patient. So, welcome back, Regina.
Okay, Thank you for that.
That's all right. So respiratory rates greater than 12, that's one ventilation every 5 to 6 seconds. Decreased cardiac output and perfusion. So we don't need to go faster than 5 to 6 seconds. One breath every 5 to 6 seconds. And high volume. They're finding out that, in fact, there's some research, it's not out there yet, so don't go do it. Follow your local protocols. There is saying now that they may take the adult bags off and we may be ventilating on just children bags because that's about enough air to make the chest rise even on an adult. Don't shoot me. I'm just giving you what's out there in the research that's coming. You need to stay active, reading those journals, get online journals, read those things, participate on forums that come out. Those all things can help you. All right. Questions?
Well, people
on,
they get excited in a code. They get excited and they're like, oh my God, I gotta breathe, and then they're squeezing it too hard. And like, you've got to pay attention whenever you're breathing for somebody. You are their lungs. You've got to calm yourself down, get yourself together, and don't just squeeze the living crap out of that bag. You're gonna blow their lungs out. Just because the bag, the thing is got enough air in it, doesn't mean you need to squeeze it completely flat.
Yeah, I've seen in the old days people squeezing ambient bags between their knees to make sure they get enough air in. And that was because they were using the two-finger encircling method to hold the mass down so they could force it in real hard. Yeah, no, not good.
They need
not
more
good.
oxygen. I gotta get it to them faster. Let me squeeze it harder, faster. No.
Well, the thinking is this: they don't have oxygen, so I need to put more oxygen in there. And if I put more oxygen in there,
Exactly.
that'll be better. No, doesn't work that way. Slow it down. Anybody got an idea what we can use to help us keep that time right?
For the compressions or breathing?
Breathing.
Count, sing. I don't know.
Got a phone here. Let me see something.
They used to say every time you take a breath, give your patient a breath, and that doesn't work either because when you're breathing fast because you're excited, you're breathing too fast for your patient.
True.
So that doesn't work either.
That doesn't work either. All right, let me look here. Just a minute. It's got to do this. All right, a timer.
I or sing to myself, and folks with compressions. That's kind of something I've tried to do. Like y'all said, try not to get excited and breathe, help, with the patient and not your.
Breathe. Somehow get a counter, something that counts down 5 seconds. And then it comes down again, 5 seconds. And another one. Get you a metronome. Get you something that works. Okay, we've got to shut you down now.
Sometimes I think in our area we put some of the least trained people doing the breathing because we use first responders for that. Even though it's still our responsibility, we should be telling them how to do it. But that's typically where you put the first responders and stuff, and they get really excited and worked up as well.
Yeah. And guess what? There is a new group person added to the ACLS mega code. The in-hospital mega codes will now have a person called the CPR coach there to time the ventilations and there to time the compressions and there to give you feedback. You're breathing too fast. You're compressing too fast. Slow your breathing down. Slow your compressions down. Okay. You're not going deep enough. You're riding the chest. That person, those are the ones that's going to be thrown out of the resuscitation effort, I'm sure. But we've got to do something. And understanding that there is a problem with hyperventilation and the problem with hyperventilation can lead to patient death, we need to change it. Where does it start? It starts with me. I need to be aware of it and understand it. Okay, good points. Um, Todd always looked for those knuckle draggers, those guys that have like huge upper torso biceps. Come here, let me teach you how to do compressions. They can do good at that because they like squashing things. All right, let's read on number 4 because we're about through with this half hour. Tissue damage may increase, and when high oxygenation levels are given to acute coronary syndromes and stroke patients, the oxygen releases, oh my gosh, these guys, free radicals. What is a free radical? Well, a free radical is a byproduct of metabolism. All right, life begins, ends, and flourishes. We're in the cell. So here it is in the cell, and we get too much oxygen going in there, and it's going to create free radicals. Free radicals are toxic. When they get out of the cell, they go to the other cells around them and they cause damage and destroy membranes. As they destroy membranes, that releases the lysonal sacs and they destroy more membranes. And then the tissue damage and decay continues to expand. And if you kill enough cells, you kill an organ. When you kill enough organs, you kill, whoa, you can kill the organism. Are all y'all okay? Hang on a minute. I just got to notice that we are unstable with our internet.
It was a little lag, but you're better now.
Okay. All right. If it gets too bad, let me know.
It's pretty
So,
cool.
so free radicals, it's out there. All right. And it can destroy the membranes and it can cause tissue death and it can cause organ death and it can cause death of the organism. So reintroducing high concentrations of oxygen to the cell have been functionally anaerobic. Anaerobic means this cell has been working in its survival mode. In the survival mode, the cell switches from aerobic metabolism to anaerobic metabolism. And anaerobic metabolism is like trying to drive your gasoline burning vehicle on diesel. It will work, but it'll make lots of smoke and it will not work as well. And it will release free radicals out its tailpipe, which will damage other things around it. Well, if you switch a cell from aerobic to anaerobic, and then anaerobic back to aerobic, because you change, that releases those free radicals, and the cell membrane will be damaged, and there'll be tissue death. So, do not deliver high concentrations of oxygens to acute coronary syndromes and strokes because it may be more harmful than keeping the patient on 21% room air. Sure is quiet in here.
I totally agree.
Good. It's not me saying this. This is the experts. This is the National Registry of EMT. And if you look at other studies that's out there, this is proven fact. This is evidence-based medicine. This is where we're going. We got to have evidence for what we do in the field. A lot of times back in the good old days when dinosaurs roamed the earth, they come up with something and said, "Hey, this works. This looks good," and we did it. And it was not because it was proven. It was because why? Because it looked good, which is wrong. Anybody have any questions on that section? And that was the oxygenation section. Tell you what, let's do. Can we take a break? Let's go powder our nose and let's try to come back. Oh, how about 9:35? Can we come back at 9:35 and we will once again get after this? Okay. Pausing the recording.
It's going more south, I think, than it is more beneficial.
And I don't know. I live in the South because I like South. So when things go south, I go, "Hey, it's coming home."
Well, that's true, and I agree on that aspect. That's kind of funny, and you're right. But I mean, as far as it's going more, this whole thing about this whole COVID ordeal seems to be going more negative than it is being any help for any of us.
True, true. Okay, let me hit this
Could
up.
agree.
Is that better? Can y'all read that, or do I need to go down some?
That's a little bit better now. It's blown up a little more. It's kind of hard to
Okay.
follow, especially when you're on the phone.
I know, and that's why I try to blow it up. Okay, so what we're talking about for the next half hour, which will be through about 10 o'clock, is the understanding the function of a ventricular assist device, a VAD. Some people call them LVADs. I've got several different types, and I do have a handout that I can send to you that my friend Brian Duncan sent to me. He has apparently dealt with some patients that have been here in their area that have been on these ventricular assist devices, and they are usually put in Tulsa, Oklahoma. Now, ventricular assist devices. Should I ask y'all what you know about them and see what you say, or should I just kind of drone on here?
Me personally, you can talk about it because I'm still learning.
Okay, Regina, are you there? Are you still stuffing sausage and biscuit in your mouth there?
No, I'm here.
Okay, tell me what you know about LVADs or VADs.
Basically, it's the the left ventricle of your heart. It's what pumps. You will not have a pulse, and you carry your left ventricle on the outside of your body.
Okay,
And if your battery runs out, you're dead.
that's why they always carry what?
Two
batteries
charged.
and the wall conversion unit that plugs into the wall so they can be not only a direct current, but they can go to alternating current. You're right.
Mm-hmm.
You're right. Now, there have been some new advances, and LVADs now are not just outside the body. They're actually putting them inside the body, and they're using some kind of a microwave technology to get the power in there to run them. So
Mm-hmm.
when LVADs first came out, and I remember the future. And LVADs first came out, they were huge, the things. They sat beside the bed. The patient had all these hoses that came in and out, and sepsis and infection was one of the biggest things they had. They were not getting up and having any type of life. Basically, they were in the bed, they were in the chair by the bed. That was it. And it sustained them until they were able to get a transplanted heart. The modern LVADs, the Jarvik 2000 and some of these other ones that's out there, these people carry on normal life. They get in cars, they drive, they do all this stuff. So you may run into one of these somewhere down the road. You said it didn't have a pulse?
Nope.
Huh. Why would they not have a pulse?
Because it's continuously running.
Well, if they don't have a pulse, then they probably wouldn't have a blood pressure.
No.
Oh, Now that would freak me out. Somebody talking to me, carrying on in conversations, cognitive, having good cognitive ability with no pulse and no blood pressure. Okay, it's true. It does that. You can get a systolic pressure if you pump it up high enough, but blood pressures are not necessary. And they'll let you know that they have an LVAD or a VAD. Um, they are implanted in heart failure patients. Patients' heart is wore out, old and wore out. Their ventricle, their ejection fraction. I've seen people with ejection fractions down less than 10%. They would be candidates for LVAD, and they are put in as a temporary treatment for patients that have very low cardiac output, and then they're put on a list so they can get a transplanted heart. So, how do you assess these patients? Well, it's basically the same thing, but you may need to remember, like Regina said, there is a continuous flow, uh, so they won't have a palpable pulse or a measurable blood pressure. You listen to the chest, you may hear a whirring sound or a humming sound, which means that the LVAD is working. If the LVAD doesn't work, you will have to do CPR on them. SPO readings, because they are pulse oximetry. If you don't have a pulse, you may not have pulse oximetry, so it may not work. End-tidal CO2, though, does work. All right, so let's say that. So their mental status, skin settings are going to be the most helpful thing to show you whether they're pink, warm, and dry or pale, cool, and blue. You're going to get a cable that comes through the abdominal wall, connects to that power unit outside. And a lot of these VAD patients, if they go into a ventricular fibrillation, do have a internal defibrillator inside their chest, and it will shock the patient. So a lot of their hospital admissions are not from cardiac problems, so to speak, but from, like I said, infections, especially around where the insertion point comes in. And that's why the newer machines, and these newer machines have come out since this was published in 2018. Uh, they are totally wire free. They're totally free from things. They just got to carry this battery pack or wear it on their belt, and it connects by sensor somehow to get the energy through the side of the wall of the abdomen. But sepsis is going to be there. And who's going to be the most knowledgeable person there about the LVAD? Will it be you? Will it be your partner? Or will it be the patient's family that has gone with them on this journey for the LVAD and gone in and found out how they can deal with it? So ask the family what's going on. Now, the family are going to have an identification card that's going to have contact information for what is called a VAD coordinator. And do contact them, because if you contact them and tell them what's going on, they may direct you to transport to a place where they can provide transport to the destination. They may send a plane, they may send a helicopter to get there. So you need to know and contact that VAD coordinator. But now, if they're in cardiac arrest, you're just going to have to do the best you can with the CPR. So allow the patient and caregiver to guide your interactions. Keep batteries and controller within reach and secured to the patient. Do not separate them from the battery, because if they run out of battery, they need that extra battery. They may need to plug up their alternating current, their house current plug, and plug that up to the inverter of the truck. So, when you cut off their clothes, be very careful. There's wires and things in there that should not be cut. And if chest compressions are indicated with the patient's specific device, consult the family, view that VAD
There we are.
identification card, and
Okay.
consult the VAD. All right?
Who you talking to?
Casey Jones. Look who I found.
Hey, Danny.
Hey, Danny.
How you doing?
We are doing good.
Still
There you
both
go.
around.
Yeah, still floating around.
Yeah.
Retirement doing good?
I've got to find stuff to do.
Oh, there's always stuff to do. I heard
I'll
where
be taking care of it later.
I heard where Harrison's looking for bus drivers.
There you go. There you go.
Yeah, that's even worse than ambulance.
Hey, it has red lights. It has red lights.
Yeah.
There you go.
Yep. And speeders.
There you go.
All right.
Good to see you, sir.
All right. Sorry for interrupting.
See ya.
Oh.
All right. Let's go back. All right. Any questions on LVADs? Let me, I'm going to jump out here and check on something. Come on. I think I'm going to see if I can find this. Hang on. If I disconnect from everybody. Nope, 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 nope. Don't do that. Nope, nope, nope. All right. Never mind. I can't do that. All right. So I got to go this way. Huh. You ever been just sideways here trying to figure out what's going on? There we go. Anybody had any dealings with anybody had any dealings with these LVADs?
I did an ER back when I was just an LPN.
Okay. Can you share any of that with us?
It's very scary because you know just about it enough to, it's kind of dangerous because you don't really know a whole lot about it. And you know, the simple things I said a while ago, and that's about it. And you don't know, you know, trying to take care of them. You're looking for a blood pressure, you're feeling for a pulse, and like, it's kind of crazy. And you're like, oh my gosh. So you kind of watch them a little closer because you don't have all the readings that you normally would touch and feel and hear to know that something's going wrong.
And is it really true that the patients know more about it than
Oh, heck yeah.
most healthcare?
Yeah, if they tell you something, you better freaking listen.
True, true, true. All right. Did your patient have a pulse?
Nope, but they told me to go find one.
If you can't,
that's how I learned they don't.
If you can't find a pulse on the patient, you can always find a pulse on you.
Yes, well, I have one, but my patient's talking to me and he doesn't.
Yep, that is strange stuff. Let me see here.
We transferred a patient one time from North Art to Baptist in Little Rock that had one.
It's nerve-wracking.
You just worry about it, right?
Mm-hmm.
I just drove fast.
Wind blowing big where y'all are at?
I'm inside.
All right, let's see here.
Blowing good here.
Yeah, I just heard the house pop, so I know that means it's blowing real good. Hang on a minute. Now then, I need to put this back down. I found a video. Would y'all like to watch a video on an LVAD?
Heck yeah, man.
It's about 8 minutes.
Videos are fabulous.
It's about 8 minutes, so I have previewed it once before. Y'all see that screen?
I can see it.
Okay.
I can see it.
Okay, good deal. Here we go. I think the audio will be up loud enough. Apparently they make these things.
The heart has 4 muscular pumping chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. The left ventricle pumps blood out through a large artery called the aorta to supply the body with the oxygen and nutrients it needs. In left-sided heart failure, the left ventricle is not able to pump enough blood to the body. The 2 types of left-handed heart failure are diastolic, where the left ventricle can't relax enough to fill with blood, and more commonly systolic, where the left ventricle can't contract strongly enough to push blood to the body. In severe or end-stage heart failure, the heart is getting weaker and doesn't respond to medication. For left-sided end-stage systolic heart failure, a doctor may recommend an implantable left ventricular assist device, or LVAD, to help the heart pump enough blood to the body. An LVAD is a small mechanical pump implanted inside the chest or abdomen that takes over the job of the weak left ventricle. Blood flows from the left ventricle through an inflow tube to the pump. The pump pushes the blood through an outflow tube into the aorta. From here, the blood travels normally from the aorta to the rest of the body. A cable, called a drive line, connects the LVAD pump inside the chest to a control unit located on the outside of the body. The control unit is a small computer that controls the functions of the pump and alerts the patient if there are any problems. The pump and control unit receive power through a cord connected to a battery pack. Finally, the control unit and battery pack are held in a lightweight patient pack. An LVAD may be a temporary treatment until a heart transplant can be performed. Or, if the patient isn't able to have a heart transplant, an LVAD may be used for destination therapy, which is long-term treatment.
There gives you an idea of what an LVAD's about. Let's stop that. So we see these now more and more, and I guess we're going to continue to see them. Typically, some of the terminal events of this will be stroke, because these patients, the LVADs, the early LVADs destroyed the red blood cells, which caused them to go to platelets, and then the platelets made clots, and the clots made macroemboli, went to the brain, the patient died from a stroke. We cannot make the inside of these pumps as smooth as the inside of the heart. So here again, what happens naturally is better for us than an artificial thing. But it will act as a stopgap measure until these people can get to an actual pump. All right.
So Casey, does it actually clotting, or I mean, is that not a deal? Because I mean,
most of these patients.
Do you understand what I'm asking? Can you get her, please?
Okay.
I'll be right with you, honey.
A lot of these patients.
Do you understand what I'm asking?
Yeah, they're on blood thinners, so they don't have that clotting problem.
Okay. Yeah. Well, I figured that they would be, but I still didn't know if there was going to be some of those types of issues with the LVAD.
It's not as bad as it used to be. It's gotten better as they've gotten smoother and smoother and smoother inner linings of these pumps. It's the impellers.
And they've gotten a lot. They've gotten a lot smaller in size, correct?
Yeah. The first ones would stand right next to me here. It would be like the size of a oxygen concentrator. Well, old oxygen concentrators used to be huge. Now the little old ladies wear them in purses and carry them around with them. LVADs are the same way. They've gotten smaller, more efficient.
Okay.
And working better.
Okay, great.
Your patient. All right. Here we go. Let's see. Excuse me. I'm trying to try something else out here and see if I can find a better video. That one had sample all over it, and I thought I might. I'm looking for short videos. I don't want to spend a long time with them. There's a lot of good videos out there if you want to watch them, and there's some out there that talk about how to use them, how to deal with them, how to live with them. They have actually in Nebraska, they've actually put in their 100th LVAD. So the possibilities of us seeing somebody out there with an LVAD is very, 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 very. That was a neat one. Hang on a minute. Very, very, very high. Where was that at? Sorry.
If I remember correctly, I think we even dealt with a patient that had one for temporarily. It was not long. We didn't have them, but I want to say we did because I remember a battery pack and stuff that was with them that they had a connection to them. So
yeah, let me go out here. I'm gonna one more video, and just because I need to show a good video, we're gonna do this one. Yeah, let's see. Y'all see the police car on the screen there? Y'all see the police car?
Yes, we can see it. I can see it.
Okay.
Yes.
We see a lot of patients who have come to us because they're at the end of the line. They really have no other options, and they're quite ill. Receiving a heart transplant is something that very few people have the advantage of receiving. And it's a gift not only of life, it's a gift of love, it's a gift of someone else's family. So I think one of the things that we impress upon patients is that this is a gift that they have to take care of. And this is a gift that we as caregivers significantly strive to make certain that goes well for them, goes well for their family. That's one of the reasons why the team that we have and the strategy that we put forth is key.
The difficulty with heart transplant is that we have organ shortage, and in the United States we do only about 3,000 heart transplants a year, but the number of patients who need heart transplants are a lot more. So because of the long wait times, the average wait time is about a year to a year and a half. A lot of these patients will die on the wait list if we didn't have any other support for them. So LVADs have been developed to remedy this situation.
An LVAD is a left ventricular assist device. It is a small pump that gets implanted into the tip of the heart that allows the left ventricle to pump better. And it is implanted in two different strategies. The first is a bridge to transplant. These are patients who are transplant candidates, but for whatever reason they can't wait for a transplant. Either they're too sick, or their blood group and size or immune system is such that it's going to take a long time to find a transplant for them. The other type of strategy we implant LVADs in is what's called a destination therapy. These are patients who, for whatever reason, are not transplant candidates.
Once a device is fully implanted, there is a cable that comes out. We would bring the cable out from the abdomen area, and that cable is then attached to a computer about the size of an iPhone. That computer will then also need power, so patients will wear two batteries, and the batteries are typically strapped to their shoulders like suspenders, and the computer itself is worn usually with either a fanny pack or inside a bag. I think we need to remember how sick these patients are. Patients who have end-stage heart failure typically have a 1-year survival of less than 50%, and often less than that. The survival on LVADs now, the 1-year survival is greater than 90% for a lot of these patients. And long term, we've had patients who continue to live well on an LVAD for more than 10 years now. And so these devices have come a long ways. They continue to get better. Within the next decade or two, we may see LVADs replace heart transplant as a treatment of choice for most patients who have heart failure. That would alleviate the fact that we just don't have enough organs to go around.
One of the advantages of the Cleveland Clinic is just the sheer volume of surgeries that we perform here. We've had the luxury of having a very well-established and long heart transplant program. The LVAD program similarly has had great success. This really puts us at the top in terms of volume across the country.
The advantage of a place like Cleveland Clinic is the multidisciplinary team that we have. So we have a team of about 14 cardiologists and 4 surgeons that are involved in the heart failure program. In addition, we have a whole slew of other team members, nurses, nurse practitioners, a social worker, nutritionists, pharmacists, etc. And the whole team is working together for the patients.
We get referred patients who are denied surgery at some other very high volume centers. We do have a very high acuity risk. Our patients are very sick. That gives an advantage to patients in the sense that they know they're being cared for by teams that have seen just about everything.
The difference you see in patients before and after a heart transplant LVAD is one of the most gratifying experiences any human being can experience. See them back after all these years and see how well they're doing.
And we will do whatever it takes to accomplish that for every patient. It is a true gift, whether it be a transplant or an LVAD, because they're survivors.
Wow. 10 years. I had no idea. So
That was a better video.
I think so. I think so. But yeah, we need to remember that thing, and I guess it's something that we can look forward to having out there. And let me see. All right. So there you go. Um, I need to look up something just for a second. Forgive me for running around here looking, but I need to go and look at something. I'll be right back. What do you think about this LVAD, Todd?
It's a very cool technology.
Yeah, and it's getting smaller and better. I had no idea that it's been around. People have been living for 10 years on these things.
You know, it also helps with not having to deal with the organ transplant rejection as well.
Oh yeah, I agree.
Wow, great point, Regina.
I think if I had one, I'd prefer to live somewhere like Tulsa or somewhere close to Cleveland.
I don't know living in Cleveland. That may not be the best thing. You know what I'm saying?
I wouldn't prefer to, but if I had one, I would want to be in where I could get to quick.
Yeah, I'd want to be close, at least with a helicopter flight, right?
Around here, they go to Little Rock, deals with them, and when I flew, we took them to Barnes in Barnes Jewish in St. Louis, and then there's one over in Kansas that they just took one to the other day from over here at Baxter. So
it doesn't surprise me that Barnes does this.
Yeah.
UAMS, that's a little surprising to me. So
yeah, I think Baptist.
Baptist down there. What about
Yeah.
the heart hospital down there? Are they doing them?
I don't know. I would assume at their heart, you would think they would, but usually when we transfer them, they go to Baptist, and now Kansas KCU is doing them now.
Did you say you could see me? Oh, you said KCU. Okay.
Kansas City.
Yeah. Okay. Yeah. Well, as a future heart failure patient, I'm keeping all of these things in the back of my mind, because when it gets to that point, I'm going to go, hey, how about an LVAD? I'm diabetic,
Right.
I'm hypertensive, I'm heart failure, I'm asthmatic. You know, I am the poster child for catching this virus. So that's why I'm staying home and staying out of stuff.
Right.
So, you know, that we need to put in the back of our minds, because it looks like LVADs will work for us. All right.
Yep.
Thank y'all very much. Good interchange there, and that takes care of this part.
I do have a question though. You know, when we were first, of course, you know, all that stuff was pretty scary to me when it first came about in our trainings and stuff like that. We had, you know, I guess staff meetings to go over, or crew meetings, you know, to go over all that. And at one point, you know, they said, well, we've got one in our service area, and then it's, you know, we have two in our service area. Do we happen to know how many there are within our service area at this point, patients with an LVAD?
I don't know you would, unless Tulsa would send information to dispatch. I know Children's used to send dispatch information if you had a bad patient that was from Children's that was back at home. They let you know. I don't know if you know that or not. I guess we could talk to the coordinator, LVAD coordinator at Tulsa. And I guess if you did a search on that Tulsa LVAD center, they would tell you.
Because they were, I think we were being made aware of it at that point because they were still having some problems with them. I think that the LVADs are so sufficient at this point, or efficient, that maybe, you know, we just don't need to know because they're not having issues with them.
Well, you saw in that video, if you got to see the video, there were people up walking around, climbing stairs, you know, going about their everyday lives, walking on treadmills, doing things like that, because their heart is pumping, and now they have enough perfusion to do that. So it would be interesting. And as this gets better and better, you're going to see more and more of them out there. You know, one of these days you go to a car wreck and the guy will go, look, my LVAD battery got broke. I need a new LVAD battery. I do know that I talked to a person from Taney County, and they had a patient that was from Tulsa that came in, and she, believe it or not, forgot the charger for her battery. And they contacted the coordinator, and the coordinator said, oh, that's okay. Here is a number for somebody else that's in that Branson area that is on an LVAD. Contact them and see if they have an extra charger. So they did, and they got the charger, and the patient's LVAD continued to work. That's pretty neat stuff. Pretty neat stuff. And who knows in the next 5-10 years what kind of devices we're going to see that we're going to be out taking care of also. All right. Let me go up here and try to share a screen with you. We got to go on with this. We're ready to do the next part of this, which is cardiovascular post-resuscitation care. This has got to be a big deal, especially with the Heart Association. They want you to be able to handle that post resuscitation care. It's because CPR has gotten better, ventilation has gotten slower. We're now seeing ROSC numbers come up, percentages come up. And as the percentages come up, then we're going to have to deal with these patients that are now back
Far enough back.
with us.
I'm gonna go back a little further.
How far back you going?
Can you hear me?
Yeah, I can.
Well, put me back on mute. I'm fixing to go in the store.
Okay. Watch that tone. I hear it backing up.
I know. I was a beeping, wasn't I?
It was beeping. Sure was. All right. Here we go. So the part we're dealing here with is, let me get this off. There we go. It's a half hour, real short. So we're going to go from 10 to 10:30. We got to identify the signs associated with return to spontaneous circulation. We got to recognize, because we're going to be surprised this patient's back. How to handle or manage hemodynamically unstable patients as a basic. And then later on with the advanced crews in day 5 and 6 of this NCCP, we'll talk to them about how they handle it with pharmacological interventions. We're going to investigate possible causes of cardiac arrest and make the most appropriate treatment choices based on the cause. Determine appropriate destination. Not everything needs to go to the home base. Sometimes it is important to get the patient to the hospital with the capacity and capability to handle their situation. And we're going to talk a little bit about a group thing called induced hypothermia, and that will come later. So tell me, Todd, are you back with us? Are you still around, or have you gone? I would like for you to tell me about ROSC.
No, sorry, I got a work phone call, but I'm back.
Okay, you're back? Okay. How about this, ROSC? What does ROSC mean to you, and how do I know I've got it?
Return of spontaneous circulation. You have a pulse that is
it always reminds me of that.
I don't know.
You ever remember that Frankenstein movie when the doctor has shocked the patient and it's come alive and he goes, "It's alive, it's alive." Yeah, that's what this is. The patient has been dead. We've pushed hard, we've pushed fast, we've ventilated them, and now what are they? Alive.
Alive.
Yeah. And how we know they're alive? They got a pulse, right?
They have a pulse.
Right. You're going to see an organized rhythm on the monitor. The patient is breathing. The patient is moving. The patient is telling you, "Quit pushing on my chest. That hurts." The patient has perfusion. And if they have perfusion, if they have a pulse, anytime in a cardiac arrest event, if you get a pulse back, the next thing you need to get is a blood pressure. I would even advocate, if I was still on the truck doing that stuff, when I was doing CPR, I would connect the blood pressure cuff to the patient, even while we're doing chest compressions, because as soon as I get a pulse back, I am anticipating getting a pulse back. And when I get a pulse back, I want to know the blood pressure because I want to know if they're hemodynamically stable or not. I'm also going to be having end-tidal CO2. And end-tidal CO2 will tell me whether or not they are perfusing. End-tidal CO2 should be between 35 and 45. If you're doing CPR on somebody and the end-tidal CO2 is coming back less than 10, you're probably beating a dead horse. Patients do not come back if their their end-tidal CO2 is less than 10. It's just the cellular metabolism is not there. And that's what you're measuring with that. SpO2 of 94 or more, oxygen's not necessarily better because we don't want to release those. Squirrel, what are those things we release when we give too much oxygen?
I'm sorry, can you ask the question again? I apologize. I'm dealing with a medical from the hospital as well, so I apologize for that. I took a phone call from them. I'm dealing with our EM healthcare.
I'm sorry, I don't have my camera on, so I can't see you.
No, you're fine.
If I call on you and you can't answer, that's okay. Just don't answer, and I'll go right on.
No, that's fine. What was the question, real quick? I mean, I apologize. I'm not ignoring you.
It's all right. Golly, I done forgot what the question was. It was there for a minute. Now it's gone. Go back
I'm
to
so
it again.
sorry.
It's okay. It's okay. Um, we've got perfusion. We
You
don't,
would ask, what are those things, Casey? You asked, what are those things that are released when you get too much oxygen?
and the answer
Too much.
is
Too much oxygen? What's
yeah.
released
At the cell level, those
at the cell level?
free what?
Oh, something
Radicals.
biscuity. Oh,
Radicals.
radical. Are you talking
Yeah,
about the radicals? Oh, the invasion of ISIS and all that? Okay.
yeah. There you go.
Okay. Yeah, that's that. We're getting invaded by ISIS when you have too
Yeah,
much oxygen.
got those radicals coming out there, yeah, and causing them lysosomal sacs to rupture. So don't overbag them, because it reduces cardiac output, it releases free radicals, and it decreases cerebral blood flow. Hyperventilation even decreases cerebral blood flow because you drop the preload, you drop the afterload, you drop the blood going to the brain. Not a good thing. Okay, so get a pulse, get a blood pressure, get a pulse, get or ensure a vascular access. Well, you guys can't start IVs. So if you're in a code situation, you hope that the cavalry is coming. What cavalry? Either an ALS truck or the gods of the air, the rotor wing people. So they're going to come in, but they're going to need to get that vascular access, and they need to monitor for cardiac hemodynamics. And that's if there's blood pressure adequate enough to maintain perfusion. Hypotension in these patients are less than 90. We don't want to get them to 120 over 80, but we'd like to get them about 90, 94 on their systolic pressure. So ROSC and post-resuscitation care is to ensure the coronary reperfusion. Coronary reperfusion, that is where we get oxygenated blood once again going to the myocardium. And most of the deaths following ROSC occur within the first 24 hours. Why? Because those are the sickest people. My gosh, they were dead not too long ago. Now we got them back. Their heart's pumping again, but they're still sick because it may take 24 hours, you know, uh, to be outside of the danger window of being lost. So we got to transport them to the most appropriate facility. Now, if you're still pushing hard and blowing, the most appropriate facility is the closest port in the storm. All right. Just like with a trauma, if they're bleeding, you got an unsecured airway, the closest facility is best. You get them back, they're hemodynamically stable, they're having heart issues. The closest port may not be the right one. You may need to transport them to a heart center that has uh, heart cath capability, PCI capability. And the nearest one here is where? Anybody.
Branson.
Cox Branson. That is the STEMI PCI Center. If you're farther enough down south, I don't know down south. Anybody from Marshall on here? What's the nearest one down that way?
I think Conway is, isn't it?
I really don't know. I haven't done a lot of study on that. Go ahead.
I believe it might be Conway because I know we do transfer patients.
Branson, we take them to
cardiac
Branson.
patients too.
Yeah, Branson
From
is.
Did you hear
Marshall,
me,
you go to
KC?
Branson?
Yes, Branson is.
Yeah, we
still,
go to Branson.
Okay, all right, good deal. But we need to get them there. The cardiac centers, there's some in Little Rock, there's some in Branson and Springville. Washington Regional is a cardiac center, but most of those are stabilized and then sent from the hospital to there. Now, let's get to the big elephant in the room, and that is going to be therapeutic hypothermia. Therapeutic hypothermia. What in the world is that?
Well, that's going to be where they are making the patient hypothermic in a controlled setting so that they can heal and go on, hopefully leave after ROSC instead of having that other, leave out the back doors.
Yep, they leave one way or the other. Yeah, and there is therapeutic hypothermia out there. In fact, I was in Kansas for the one of the EMS meetings up there, and they were trying to get a grant to put these hypothermic bear huggers in the trucks to put therapeutic hypothermia on the trucks. Now we don't do that here, and you get them down to about 34 degrees Celsius. Uh, and you keep them there for 24 hours, and these patients have a remarkable recovery rate. I was looking to see if I could find a good therapeutic hypothermia video out there that's good. I don't know one right quick. Uh, Sometimes you look at these and you don't know if they're any good or not. Um, but the best part about them is they're short. And that's the one you want. They use it also in babies. Um, the rest of them are just talking heads. I don't think I'll do that. It's cute. Does our hospital do any therapeutic hypothermia?
That I'm not too sure of. I think that they do a little bit, but not to the extent. I don't know. I have heard of them doing maybe starting the process before they can be transferred to a facility that actually does.
Yeah, and it's worse for these patients if they're cooled and then warmed back up. So they don't want you to cool them down and let them get warm again. And they basically keep them there for 24 hours. Uh, yeah. They also do it in neonates too. So it's not a just a heart attack situation. But there you go. All right. Got through that a little quicker than we did. I got this. Let's see. Okay.
I'm somewhat back. Sorry about
Oh, that's okay. Everybody's got stuff they got to deal with, and I understand. And
all that. Well, this
no,
whole issue is putting my job on the line.
oh, I know, and it is tough. Um, okay, let me go back out this way, and it's time to look at something else. Let me get rid of that. Come up with this. Need to look at this, and I'm going to come back to here. I'm getting better at this. I'm going to share this screen, and y'all going to have a whole bunch of little stuff there, but hang on just a minute. I'm going to zoom in on it. Let's see. Go plus. Cancel. Okay, I got to do that. There we go. And maybe I can do it now. Mm. Well, we're looking at right here, day one. So we've had ventilation, we've done oxygenation, we've done post-resuscitation, and we've done LVAD. So we got now strokes, cardiac arrest, research, and then we'll be through. So we're moving through here pretty good, and we're right on time. Stroke is going to be the long one, though, here in just a little bit we're going to get into. So um, there we go. I'm back from stopping sharing. Are you getting any? Well, hang on. Wow, that's wrong. Something has gone wrong here, Houston. Nope. There we go. So how we doing? Give me some reaction there. Some of your emotion reactions. Are you getting something out of this? Is it good? Is it needs to be nothing? Are we beating the same horse over and over?
Getting something out of it.
Okay, good deal, John. Appreciate it. And okay, Regina is somewhere where she can't talk, and that's fine. We'll just continue right on. As we do, we're going to be going with, gosh, stroke. Yeah. And I'm going to go out here as I know where these are at. Uh, We're going to start talking about stroke here. And what I want you to do is this website right here is the UAMS stroke program. This is where Arkansas Saves is located. And this is their homepage. And there's media. And you can go in here, and there are all kinds of media stuff in here. Where they've gotten their innovation. This is going to be Institute for Digital Health. They've gotten money. The Oklahoma police sergeant, after a spinal stroke, uh, while out on vacation, that's a pretty good one. So you've got all these kind of interesting things that they've got, and this one right here is a local patient. And let's see if I can get this. And I thought there was a video involved with that. I guess not. Sorry. There it is. There it comes. I see it. All right. You ready? We'll watch this news. And this is from Arkansas Saves. And they're always looking for Arkansas Saves information.
Doing what we love can be painful. Introducing Aspir Cream with essential oil. Now calming lavender oil is combined.
Of course, we have to get through the ads when we do this. And that's because your instructor is too cheap to pay for.
Well, a stroke victim thankful tonight for doctors at UAMS. Their quick response means instead of a life of paralysis, she was able to walk out of the hospital just days after being rushed to the ER.
Hubert and Erlene Smith have been married for 66 years. On Halloween, the 84 and 82-year-olds were in their apartment. It was just life as usual until it wasn't.
She came in and sat down as usual, and I asked her, I said, do you want some coffee? And I asked her a second time, she wants some coffee, and she wouldn't talk to me.
Erlene was having a stroke. Hubert knew his former nurse was in the apartment next door.
First thing she said, oh, she's having a stroke. And I said, well, I'll go get the car and we'll take her to the ER. And she said, no. So she called 911.
That call may have saved Erlene's life. 911 issued a stroke code to UAMS, so when the ambulance arrived, doctors were ready to act immediately.
Dr. Fries is down there to expedite the whole thing. Instead of patient having to wait, patient will be taken to the CT scanner right away, and TPA will be prepared right away.
TPA is a clot buster, but only helpful if the patient gets it quickly.
The original stroke size was this big, almost 1/3 of her left side of the brain, or even more than that. After the clot was pulled out, when the MRI was done the next day, her stroke size was only this one small little dot.
I cannot tell people enough about the crew here and the service saved her life.
Hubert and Erlene are back in their apartment, back to their lives as usual. The quick response means Erlene didn't even need rehab.
And the people on our floor in our building where we live, they just keep saying, there's our miracle.
She's been talking good, she's been walking good, and she's been eating good and sleeping good. And I don't know, we might have another 66 years.
Here's hoping they get that next 66 years. Well,
morning, new Center for.
But that's not unusual. I mean, we can do the same thing here. I've heard stories that our Arkansas Saves hospital here has done the same thing. We just don't get it out on the news. So is it important for these news stories like that to get out?
I do believe yes. I mean, it helps promote the showing that we care, that we're serious about how we're taking our healthcare providing services. I mean, sometimes we always like to think news is all it can be bad, but in some cases, news can help and promote the care and seriousness that we as healthcare providers are honestly trying.
Who actually caused? I think her name's Erlene. Erlene to get the care. It was who?
That part I didn't catch.
Who sat down beside her and said, "You want a cup of coffee? You want a cup of coffee?" Her husband determined and made the detection that she wasn't right. She's not acting right. And then he went to seek help, and he went to the neighbor, and who was a nurse, and the nurse then said, yeah, she's probably having a stroke, she needs to go. And then what did the guy do? What most people in Arkansas do. Let's what? Put them in the car and take them. But that was the wrong thing to do. And that's what the video showed, that by going by ambulance, it got her in quicker, and she didn't even have to go through rehab. Now, let me tell you, that just blows my mind, because in the early days, in the 70s, when I first got on the street, they actually had patients that would have a stroke, and we would basically just pat their hand and say, um, you know, the problem is you have had a stroke. Here is some good uh, nursing homes that you can go to, because we couldn't do anything. People wait an average of 12 hours to seek help. This little lady here, it was almost instantly. She come in and sat down, so she was being normal at that point. But when he talked to her, she did not interact with him, and he knew then there was a problem. That was one way to get a good trick or treat on Halloween. So stroke has changed in Arkansas. Our stroke treatments has changed in Arkansas, and it is probably changed for the better, I might say. So there we go. So when we talk about stroke, you see all of the billboards. We need to have education out there for the lay people. The lay people need to understand that strokes time is important. Time is brain. You've got 4, maybe 4.5, maybe 5 hours from the time of the onset of symptoms until you get to that TPA. Not everybody's going to get TPA, but we've got to recognize it quick. So the Heart Association and the American Stroke Association has come up with this FAST. Now, FAST is not the one that is used in in Arkansas. We put 2 letters in front of it. It's Be Fast. Does anybody know that acronym? Do you know what it means?
And B, your balance, and
Balance.
then facial droop, your facial expressions. I went blank on the A.
Arm drift. That's right.
Arm drift. There you go. Okay. And then slurred speech, and then I went blank on the T as well. But
time.
Time. There you go. Okay.
Yeah.
Okay. Thank you.
We've got to know that it's Be Fast. There it is right there, if you can see it on the screen. Is it a stroke? Balance, eyesight, face, arm drift, speech, and time. The time is, time is brain. So we need to call as soon as we can. And we need to make sure that this is getting out. Hypertensive patients need to be receiving this information. People that are on blood pressure medications need to be getting this information when they get their prescription. They should be looking at that going, if I got hypertension, am I more susceptible to having a stroke? Of course, we all know the answer to that is what? Yes. And they need to know where to go out here to find this information and this data. Call 911. That's the big thing. But this is the UMS stroke patterns, and they have resources out here. And you can go out and click on any of these. There's a local event. They can even bring out the mega brain. They've got a huge mega brain that people can walk through and see. And that's a neat thing. And then there is some credentialing things and websites. And Harrison is one of the AR saves, along with um, Ozark Health is one. I'm trying to think. Baxter is one. So we've got a lot of AR saves hospitals that are around. And this is the American Heart Association's fact sheet on stroke. And those are things you can look at. And they have it in all kinds of different ways. And they can do answers by the fact sheet. So you can click on those and look. But you need to know where the resources are at. And knowing the resources that you can share with patients. because suddenly you guys being the EMS provider in your community, they will look at you and go, okay, what about this? I am now on blood pressure medication. What does that mean? And here there's the are you at risks? And it talks about all the things that go through, and you learn the risk factors. And mostly what we're doing here with this type of training is getting this information out to you, so you will know that where to go and find stuff for patients. Uh, the information age is here, and there are just tons of information out there. And all we got to do is look for it. Go out and look for it and find it, and it it's there. It's free. It's free for the taking. Yeah, I want to do this. There you go. Here is this is the old Cincinnati scale. Arkansas has added the B fast to it. This is just fast. This is from the Heart Association, and it's pretty clear, straightforward. Telling people, if grandma says her arm is tingling and she can't hold a coffee cup, or she is having problems with arm caping a hold of things, or she quits talking and starts talking her words strange, then yeah, we need to get active on it, because if we get that going quick enough, we can save these people from having a full stroke. Okay.
That happens with my grandma. EMS is getting a call because that's posted on her refrigerator.
There you go. That's the kind of stuff that you need to look at, and get out there. Recognizing it is the first thing. Recognizing it is the first thing. Now, is no me. Let me see here. I got a video I want to show you. Okay. And get the right one. All right. Let's see. All right. Maybe that will work. Hang on a minute. Whoa. Okay. Whoa.
Hey, Casey.
Yeah.
Casey, I did do some checking about the therapeutic hypothermia here at North Ark. We do not do anything here. They do, however, do it in Branson.
Okay.
So our patients that are transferred out after Ross that possibly require that will go to Branson or Little Rock or I think Fayetteville.
Okay.
But Dr. Shearer said I most likely am going to go to Branson because they do it there.
Wow, that's good information. Thank you very much, Jimmy. Appreciate it.
Sorry, I didn't hear that part. We do that in the ICU there, but I think they only have like 2 machines.
Okay. All right.
Okay, maybe he was just talking just strictly from an ER standpoint.
Mm-hmm.
Okay, this is a news report out of LA County. This is their Channel 2 out there. And this is at the Grammy Awards. The reporter has been there. Has any of y'all seen this video? Okay, watch this. Watch this CBS reporter, and we'll talk about what you see when this happens.
Lady Antebellum was the big winner tonight with 5 Grammy Awards. Rapper Eminem, the big shocker, winning only 2 despite 10 nominations. CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy debatation tonight. We had a very Darrison bite. Let's go ahead, Terry's and look for the head of the pit.
All right. What do you think about that?
Well, slurred speech. She started, right in the middle of her news report, she was starting to lose her speech completely and mumble her words.
Really was. This was on live TV. I guess thousands or maybe millions of people saw it. And the paramedics responded to it. She said, I just want to go home. It cleared up almost instantly. And what it amounted to is she was having a form of a migraine. So migraines, cluster migraines, can cause this type of speech problem. it looks like a stroke, it acts like a stroke, it quacks like a stroke, you're going to treat it as a stroke. But if it turns out to be a migraine, that's okay because she has all the symptoms of it. And I don't know why they did the.
We had a very Darrison.
Look at the symmetry of her face.
But let's go ahead, Jason, the bit that had the pet.
Yeah, what's that now?
I said the symmetry even looks off a little because that's what I was trying to focus on to see if she was causing any droopage or anything. And it did show slightly, but again, well, that was froze down. But even in the actual live version, it was subtle. You could see it, but I guess it wasn't so, what's the word I'm looking for, where it was so, you could literally just, everything's falling. You had to actually look at it.
All right, here's the start of it. Notice that the left side is not as high as the right side.
Yes, sir.
See the dimple here? There's no dimple there. I mean, there's subtle things.
Yes, sir.
And my favorite thing I like about this video is watch the expression on her face when she realizes her brain tells her you're not saying the right words.
Stage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy
right there. She's kind of like, this ain't right. Something is going on. And that's what they have the 5Ds for stroke. And that 5Ds is going to be for detection is the big thing. And the first thing out of the group here was they did get her out. She had no problems with this, and they actually she got better. And her doctor went on went on national TV to CBS Good Morning and told them that she did not have a stroke, that she had a cluster migraine. Who knew? What other things can mimic a stroke?
Real quick though on that, how do they tell that? How do they tell the migraines is what causing it? Because again, we were treated as such as a stroke because we're out in the field, we take it in, doctors do all that. So how do they honestly tell all that? Because I mean, it's interesting to learn, but how do they tell?
EEG studies, they put things on their brains and on their skull, and they read the waves, and that's how they tell.
Oh, gotcha. Okay, thank you.
So, okay. Somebody else had something else they're going to say?
Blood sugars mimic strokes.
Ah, yes, blood sugars. Hypoglycemic patients. Yesterday during our ACLS class, I can tell on myself, I was a little stressed doing ACLS with my peers. I always get nervous when I get around my peers. You guys make me nervous because I worry about what I say. And yesterday, my blood sugar dropped to 47. I got numbness around my lips. They started hearing me slur my speech, and thank goodness that somebody had a stash of Snickers and somebody had a stash of money that could buy me a real Dr. Pepper. And I ate a couple of Snickers, drank a real Dr. Pepper, pure sugar stuff. Tasted terrible. I don't like that sugary stuff anymore. Anyway, I did finally get back up to 97, and I'm doing well today. And the reason I knew that I had that, I've got one of those Freestyle Libres. And if you've never seen a Freestyle Libre work, they are super keen. It's a patch on my arm, and I take my phone, put it over the patch, it reads it, and then you can actually see my blood sugar right there on the front of the thing. And
Good job.
If I go too long, it'll actually tell me that it'll make an alarm. Now, the thing about Freestyle Libre and all these devices is with one touch of one button, I can check my 7-day averages. 7-day average, I'm a 125. I'm 122 for my 14 days. And look, they're all green. That's good. And then my 30-day, I'm 127. And for my 90 days, I'm 127, which will give me an A1C about 6.1. And that's the big thing. It puts you in control. As you eat, you look at the Freestyle Libre numbers or the Dexcom numbers, and you can have that. And if you go out on a diabetic, Ask them if they've got one of those devices, because it's stickless, it's painless, it doesn't hurt. It hurts one time every 14 days when I put the sensor on. But you're right, diabetics can mimic a stroke. Migraines can mimic a stroke. And you treat hypoglycemia in accordance to your local protocol. What do we do for hypoglycemics? Well, yesterday they got Snickers and full Dr. Peppers. I usually have in my pocket, I don't have right now, glucose tabs. And they should carry glucose tabs. And if they don't have that, then you can give them concentrated orange juice, anything that has a high concentration of sugar to help get them back up. So evaluate their blood glucose levels before you ever jump into the stroke protocol. Uh, and one of the other things you've got to consider is pediatric patients that are having stroke symptoms. While they're rare, do happen. So pediatric strokes uh, are pretty. They can occur. And I was going to do this because I did it with the last bunch. I've got too much open here. All right, I'm gonna go back, get off of that, back off of that. I know y'all are looking at my screen, and that's okay. All right, now I'm gonna go here and do this. Pediatric strokes, yeah, they do occur. And I was looking right here. This is the interesting part. Then this comes from the children'shospital.org, which is all the children's hospitals. There's about 14 of them in the United States. Pediatric stroke is a rare condition affecting 1 in 4,000 newborns. 1 in 4,000. That's a pretty still significant number. And if you want to know more, you can click on here, John Hopkins, and go out to pediatric strokes. 1 in 400 newborns, an additional 2,000 older children each year. So, yeah, if you think about number of kids that are there, so what do they have? Just like regular strokes: weakness, numbness on one side of the body, slurred speech, trouble balancing, they fall down a lot, vision problems, sudden lethargy or drowsiness, and seizures, unusual rhythmic movements of one or both sides of the body. So those may be signs of stroke. And they've got risk factors listed there, and one of them is heart disease and problem with blood vessels, supply of the brain, blood clotting disorders, and sickle cell patients are prone for strokes. So, we got to remember, we got to know that that's a possibility. And if that's a possibility, then we need to be able to take care of the patient. So they do happen. Now, we use the tool, Be Fast. Don't use LA. Don't use Miami. They're in the ESO, but Arkansas Saves gathers data. And as the PCR dude will tell you, if you use LA or any other stroke scale other than the Be Fast, you're probably going to get dinged and be told AR Saves requires us to use the Be Fast because they gather data from this. If we have an interaction with a patient, we take them to NARMC and we call a code stroke. They go in, get a CAT scan. And of course, we're only going to call a code stroke if they have a positive BFAST score. Because if they get a positive BFAST score, we put what on their wrist?
Stroke band?
They get a stroke band.
That's right. And it gets a stroke ban. And if they get a stroke ban, they instantly go into the drawing for a monthly review by the PCR guy, who's going to read all of those strokes and come up with data for strokes. I will share that data with you here in just a minute when we get toward a little bit further down in here. So use the right.
Hey, Casey, I have a question. I
Sure.
have a question though about the BFAST scale. I mean, what if our patients we're going up to Branson? Are they? I mean, this is an AR Saves deal. So what if we're transporting, over state lines?
That's a good question. You know who can answer that for you? Our stroke coordinator for EMS. You know who the stroke coordinator for EMS is?
Nope.
I will tell you. No, not me. I'm just the PCR dude. That's Jess. Jess is the stroke person. She is the liaison between our EMS service and the hospital. So ask her. I tell you what I would do. What I would do, Jamie, because it does trigger data points that we look at. I would go in and put a band on them, even if I was taking them to Cox, because then if we wanted to get involved with that, we could say,
And
here's
it's still and it originated here.
right, right. So it would go into the Arkansas Saves data point of patients being picked up in Arkansas and transported out of state. Okay, good?
Okay. Thank you.
Okay. I think you guys already hit on this signs and symptoms assessment assessed by and symmetry of the face. You look at the face, weakness in extremities, speech difficulties, and coordination. I had a dear friend that was a paramedic instructor, and he was at home changing a light bulb, and he was on top of his snack bar changing the light bulb up high, and as he put the light bulb in, he dropped it. And then he suddenly realized that he couldn't raise his arm back up, and he turned around, sat down on the snack bar, and he looked at his wife, and his wife went, "What's wrong? What's wrong? What's wrong?" And he couldn't talk. He still could think what he was saying. He could think what he wanted to say, but it wouldn't come out of his mouth. He became totally aphasic. So she helped him off the snack bar, got him to his lazy boy, and immediately called 911. Well, the 911 EM paramedics showed up, paramedics that he had trained, and the first thing they thought was, oh my gosh, he's having a heart attack. And he was trying to explain to them, but he couldn't talk. He couldn't move his right arm. And it took them a little while before they got into the understanding that, hey, he's aphasic. He may be having a stroke. And they picked him up, took him to an AR Saves hospital, which immediately got him in and got some TPA, and he got totally recovered without any problem. So AR Saves works. AR Saves works. It's one of the greatest things that we've had going for us as far as impacting stroke patients. We got to communicate those findings. When we get that out of hospital assessment tool done, we got to communicate those findings to the hospital. That's what we call a code stroke. We're good at that. I'll show you some data. We pull data on all that. So what do we need to do for these patients? How do we need to treat these stroke patients? Well, we need to, right there it is, Todd. You see that? Need to have supportive care. You betcha. We need to maintain an SpO2 of 94. Don't give them too much oxygen because we don't want to cut loose them free radicals. 2 liters by nasal cannula instead of the high flow mask. High flow oxygen here decreases cerebral blood flow, and the high levels of oxygen produce those free radicals, which damages cells, which leads to cerebral edema and vasodilation, which is not good. We need to give them a good dose of diesel, rapid transport to the appropriate facility, and the importance of accurately determining the time the patient was last seen. That's what the T is. When did you see grandma last at her normal? When did these symptoms start? When did we see them last? Now, some strokes are treated with endovascular interventions. They go in and do, angioplasty, stenting, just like you would in the heart. They also do mechanical clot disruptions and clot extractions. And that is a wicked looking thing because it looks like a corkscrew. And they feed it in and they go up into the brain and they go right into the vessel that is clotted off, and they get that clot and they remove it. And those happen in major centers. Washington Regional's one, Springfield, Missouri is one. Down in UAMS is one. So those are all things that we do. Now, I'm going to stop sharing just a minute. And I'm going to go over here and see who sent me something. Ugh, sorry.
That was probably me earlier.
Uh-huh. It is. It is. It is. I'm going to go over here and do this because some of y'all may not have seen this, but this is don't update. Don't update. All right. So what we're looking at here, yeah, there are no there's no information on this page that cannot be shared. So I'm going to share it with you. We are looking at an Excel spreadsheet that is generated each month for our stroke runs. And this was October 2020. Can y'all see that okay? Or do I need to go in on it a little bit bigger?
Can you blow it up a little bit, please?
I get it big. Big is not a problem. There we go. So
Thank you.
October 2020, last month, we had 4 transfers and 11 acute runs. Acute runs is emergency runs. So in October 2020, NARMC had 15 runs that were stroke. The average age of our stroke patients was 68.4. 68.4. Female was 47, male was 53. That was kind of interesting. Now, how many blood glucoses did we draw out there in October? Of the 11 acute runs, how many got it? 11 for 100%. That's awesome. What stroke scale did we use? 91% of the time we did BFAST, and 9% of the time we did BFAST and LA. So what about EKG? What about EKGs? How many EKGs do we have? 11. We actually had 10, and that's not 100%. That's that should be changed to 90%. Scene time. How long did we stay on the scene with strokes? 14.8 minutes. What is the average scene time supposed to be? According to AR
Less than
Saves,
15.
less than 15. 55% of the time we were off the scene within 55% of the time we were off the scene within 15 minutes. 20 minutes, 36% of the time we were on the scene 20 minutes or less, and then 9% of the time we were over 20 minutes. The shortest time was 9, and the longest time was 23. By the way, on the EKGs, 5 of them were 4 leads, and 5 of them was 12 leads. Okay, how many stroke alerts did we call? Oops, sorry. 100% for that. How many stroke bands? 100%. Look at there. Last seen normal, 100%. You guys are doing good. So where did our runs go to? 9 of them went to NARMC, 1 went to Baptist Regional, and 1 went to Ozark. And how about our transfers? 3 to Washington Regional and 1 to UAMS. Well, how does that stack up from the 2019 data? Ha. In 2019, we had 109 acute runs. 96% was our glucose level for 2019. October, we had 100%. Stroke scale, we did about 82% for the FAST, 12% LA, and 9.3 had both of them. EKGs was 90%. We are 96% on that other one. Scene time, what do we have up here? I forgot scene time. What is it? This is why you look, 14.8, and the scene time down here was for, yeah, there it is. It was 14.8 in 2018. October was 14.8, but last year, 2019, was 15.4. Stroke alert went down in 2018 to 19. We went down, we went down, we went up. So we are getting better in some things. And this is all the data that is pulled. And y'all, it's amazing that you can watch this data and track how well we're actually taking care of our patients with data. I never would have believed it when I first got into this position that it would be this important. Arkansas, and this data is from the CDC, Centers for Disease Control, actually compiles this stuff. They say that blood glucose in Arkansas for stroke patients is checked 100% of the time. Nationally, it's only 98.2%. Stroke scales used 78% of the time, which is about the same as national. And EKGs are done in 78% of the patients, where nationally it's 80. This information is coming from the CDC and NIMSS. And the scene time, 15 minutes, 93%. Nationally, 15 minutes is 89%. So what do you think about that? Did y'all have any idea that this kind of data was out there?
I did, because I helped get AR Saves up and running. I just haven't seen it in a few years. We actually made it.
Oh yeah. And here is one from September. Let's see. I want to look at the scene times. I want to see what the scene time was in September. 15.4%. So we're getting better. From September to October, it's gotten better. The longest run, the longest on scene time, 27 minutes. That is totally too long. But the ages was 71% there. And go ahead.
I've only been at this, with North Ark for a short period of time, and I'm sure a lot of these other ones that are vets at this, can say more. But since I have been with this, with North Ark and all, and everybody I've worked with, it's been great. That's the one thing I can brag about is they take from what I've seen and what I've worked with and all, they take this stroke and heart stuff very seriously. And I've been really impressed with North Ark and the training that we've had and all my peers and coworkers. I mean, they take it seriously. And I can speak highly for the fact of that in my short time working with them. That's the one thing I talk highly about to everybody is they take it seriously. And when we're so, trained, and we get that training to execute that and notice those things so we can get those reports in time or, the time tissue and all that stuff. And so, again, that's just me. Again, I've been here for a short period of time, but I'm very, very pleased with how we interact and react with this types of calls and things. I mean, I couldn't speak any more highly of it.
The data that I generated, that October report, comes from, this is my worksheet. And you can see it's very colorful. We put greens in there, we put reds in there, and these are all the runs. And I go in there and I look at each one. Now, this information is not only done for stroke, it's also done for cardiac. And I'm going to go out here, and I don't think I have any problem showing you this data because it's not proprietary. It's not anything bad. All right, let me see. There you go. I tell you what, we can do 2 of these because it just works out better. I just blow up this one. Okay, so you might be interested in cardiacs, and I'm gonna bring it up now. There's two on this page, so I've kind of got one of them kind of pulled off to the side. I'm gonna share that with y'all because we're supposed to have 3 hours of this. So our cardiac patients, total cardiac calls for October were 36. And this encompasses Newton County, Searcy County, Harrison, and Diamond City. The average age of our cardiac patients were 63.9. There were 40% female, 60% male. Pretty interesting. Average scene time for cardiacs was supposed to be less than 50. We're a little bit longer than that. All right. And some of that may be waiting for a helicopter. I'm not sure. Interfacilities were 9. The cardiac patients that were acute or urgent was 25. We had 2 AMAs that were cardiac related and no basic runs. Occasionally we'll have a basic runs. 60% of our runs, cardiac runs, acute cardiac runs, took over 15 minutes to get off the scene. That's our scene time from checking on scene to leaving the scene is over 50 minutes. The longest time, look at this, a cardiac run that we were on the scene for 34 minutes. There must be a lot of stuff going on with that. But if we look here, SpO2, we had 100%. EKGs, 4 leads, we had 8%. 12 leads, we're doing better on that, 92%. Blood glucose for cardiac patients, about 56%. We don't do a lot of that. IVs was 88%. We give aspirin 64% of the time. We had 4% that was aspirin given prior to arrival. Then we had nitro and 14% with prior to arrival 4%. And morphine or pain control, which is fentanyl, we only did 16%. So that is the information. We transported most of them to Cox Branson, 9. 7 of them came to NARMC. 6 were air referrals. So we called the rotor wings to come pick up 6 of our cardiac patients, and 3 of them went to Baxter Regional Medical Center. And then we did our transfers out. 4 went to Cox Branson, and it was interesting. Of these 4 going to Cox Branson, that would have come from NARMC. So so we double tapped some of these patients. Interesting point there. White River got 4 of them. So that was October. And if I slide to the left here just a little bit, Now you can look at September and October together. 37 in September, 36 in October. Average age 63.5, 63.9. Look at there. More females in September than in October. I guess hunting season may have had a part to that. I'm not really sure. 600 facility, 28 to 25, 3 AMAs, 2 AMAs, and no basic runs there. Scene time, look here. The scene time here was 20.1 minutes. And then we cut that by 3 in October. And then statistics is just great. I really do enjoy reading these charts and putting that stuff out there. And we've got it for every month. I can go back to January and tell you how many we have in. And January was a busy month, 35, 27, 37, 31, 31, 45. June was a big cardiac month, I guess because we got out and about. July, 35, 36, 37, 36. What will November tell? Well, we'll just have to stay tuned and look for that one a little later on. Anybody got any questions on the cardiac or stroke data that we can share?
I don't know about sharing, but when and a lot of my peers and coworkers and those that have been here a lot longer can definitely speak up and all by all means. I've noticed on a lot of these calls, like the ones I've fortunate to be on, the time spent, especially when we're dealing with stroke or actual cardiac, we, at least in my view, in my experience from me working, we try to make it quick, but due to where our locations are, a lot of times it's time to scene, time to patient, or getting off scene and then being down in. There was one call I worked that was cardiac or stroke, I can't remember specific, and we got down into an area where I lost complete communication. I had no service to call anything in. So if you took that in consideration and you're putting that in your call times, your ports would be greater than what you would, what we typically try to meet, our timelines we try to meet. So can I speak for that for all of it? No, but for the few that I've seen, I mean, that sometimes can hurt us due to where our locations are and a lot of these calls that we take out there, and I'd like to believe that every one of the service personnel out there on these EMS calls try to do it within the least time possible, but we sometimes are in a predicament when we get out into these rural areas and BF&E. But that's my view, and that's not trying to condone any of the lag times, but that's just from experience and seeing what I've seen so far to this point. It does make it a challenge for us.
It is a challenge.
I still have to speak highly that we do try our best, and I still am grateful for all of our personnel in EMS for trying, no matter what we get put up against.
We are urban. We're not urban. We are rural. And if you get down into Jasper and parts of Searcy County, we can even get up into urban rural. So, we need to, yeah, we do good with what we got, but we still, getting off scene, that's one of the big things we got to think about. When we get on the scene, we need to be thinking about getting off the scene as quick as we can. Right?
Yes, sir.
And getting it out there, getting information.
Parts of Searcy County like finding a new city sometimes.
So, like somebody said, we were out at we were chatting about a run that they had out near Snowball, and we actually come up and said, "Hey, you can't get to Snowball from here. You got to go somewhere else to get there."
Yeah. I'm from Searcy County. I know.
Yeah, right. There we go. There is all kinds of resources out there, and I guess part of my job with this is to make sure that you know that there's resources available to you. AR Saves is a good one. Here is the Center for Disease Control. I wouldn't go to Wikipedia, okay? Lancet would be okay. I like the CDC. I like some of the government websites. Some of y'all may think the government has some ulterior motives, but they got some information that we need to look at out there. And here's the CDC's website, and this is the one for stroke because that's what we're talking about. And they have the types of stroke that is out there, and you can click there: signs and symptoms, stroke risk, prevention, survival stories, and statistics and maps. Um, right quick, let's just click on this. No, not right now. Types of stroke, there's two types. We all know that. There is the hemorrhagic stroke, and then there is the ischemic stroke. And then they have the TIA, and that's the mini strokes, or the ones where they have loss of sensation or loss of dexterity. And most of strokes, look here, 87% of strokes are ischemic. 87% are ischemic. 100% of ischemic strokes can be cleared up with TPA. Well, if the 87% are ischemic strokes, of those patients that have the capability of getting the TPA, that means that 13% are hemorrhagic. So that means the chances of the survival is greater and return to post arrest state. But here again, we've got to get them door into the hospital within 4 hours. The 4 hours becomes the big thing. All right. TIA is the warning. People that have heart attacks, have chest pain, angina. The angina is a forerunner of the big heart attack that's coming. TIAs are the forerunner of that big stroke coming in the future. TIAs, it looks like a stroke, it acts like a stroke. We treat it like a stroke. It gets all the same thing. It gets banded like a stroke, but it is the symptoms that resolve over the next 24 hours. We don't have time to wait and see if it is a TIA or if it's a stroke. We want to treat those. Here again, it's just like the ischemic strokes because it's caused by clots. And 1/3 of the people who have TIAs don't get treatment, usually have a major stroke within 1 year. So 1/3 of the people that have a TIA don't get treated, have a major stroke. 2/3 don't, but 1/3 does. And as many as 10 to 15% of the people who have major strokes within 3 months of a TIA. So TIAs, big forerunner, big warner. So we need to look at that when we are dealing with a patient. Comment,
A quick
questions?
question.
Okay.
Yeah, I got one, and I know a lot of people will probably want me to shut up by now, but can anybody chime in? Anybody tell me the difference on these mini strokes? Because in truth, stroke, heart problem, whatever, it is as it is and all. I mean, mini strokes, especially folks that I've heard that said, "Oh, I've had a mini stroke in the past," or something mini. It almost sounds like they're dumbing it down, and in truth, you don't need to do that. I mean, it's either it is or it isn't. And a lot of times, I think with this whole word mini stroke, it's almost like and I don't say we as an EMS, but just folks in general just fail to realize it's a problem. It's not nothing to take lightly or for granted. So where do they get this whole word of mini stroke? I still ain't figured that out.
That's your difference in your TIAs and your actual strokes. The TIAs are the trans-ischemic, where it's just a mini one where it just happens for a little bit and it clears up on its own. It doesn't have to have medicine. And you usually don't have resolving from that.
And it has no deficit. Go ahead.
Yeah. That's what I was saying. There's no deficits from it.
Okay. And I'm not trying to like bash by no means. It's just my whole thought process to understand it, because when you say mini, sometimes people think, or you hear them say, "Oh, it was just and so they don't. In my view, it's almost like they don't take it seriously. And me personally, if they're having some heart problems, I'm not like pushing that to the side in my view. So anyway, thank you for that. That's,
Those that have the mini strokes are usually the ones that are going to have a big stroke eventually. So usually if they're
Right.
going to do a bigger one, they're going to have it within a couple of 24 to 48 hours. That's what your biggest,
Right.
you come in with a mini stroke, you're at risk for a huge stroke in 24 to 48 hours. You better be monitoring them.
Yeah.
Right. And that's why I took it like that. I mean, to me, a stroke, no matter how great or small, you're either going to have, if like you just said, you either have a bigger one later or you're having a big one now. It just based off of the, credentials and what we're reading and what we're learning. And so I take it all, as such and all. But anyway, that was just me, and I appreciate for commenting on that. Thank you.
Pre-hospital providers, even with the TIA, we need to be very cognizant that we can't call a TIA in the field, because it takes 24 hours for some of these to resolve, and we need to get them in for a stroke. If they have a TI, if they get in and they do the CAT scan and they find the clots in there, it's ischemic, and that's what's causing the TIA. They give them the clot busters and it clears up, and then we have a save. But we need to worry about that. 87% again is that, and when they have a TIA, mini stroke, if you will, then they are at risk for having a big stroke. I think Regina said that very well. It's the same thing with chest pain. People who have chest pains have a heart attack in their future. So
and yeah, and I appreciate it. And Regina, thank you also for commenting and all. And again, it's not because I'm trying to make it sound belittle. I'm just trying to still wrap it around my brain because it's all serious, no matter.
Oh, you're welcome. No problem.
Take a look at this right here. This right here, stroke is the leading cause of death in the United States, killing more than 147,000 Americans in 2018. That's a lot of folks. And I love this graphic right here. I wish I could, here, I'm clicking on here. Oh, is it going to do this? Okay. If you can see this map over here, it's an interactive. All adults, 35 years and older. You see anything interested in this map right here?
Arkansas is blood red almost.
Yeah, it's blood red. Yeah, and if you look here, it's the South and up toward West Virginia and Kentucky. I wonder why Arkansas,
Because we like our fried chicken and our fried products.
Oh,
greasy.
Are you going there? Are you really going to go
I'm
there?
just being more sarcastic, but I like to throw that out there because you hear it a lot. But I know that's not the case, probably.
This is heart disease of ages 35 and up, and that's I would say that's pretty young, 35 and up. But yes, we have that, and I guess the reason they have that little strip of red there in Alaska is because in that area is that lives where most of the Eskimos live, and they eat a lot of mukluk, which is nothing but fat. All right.
Interesting.
Yep. Let me go back and do this one again. Let's look at this one right here. Stroke death rates by all. Wow. If you look right there, can we zoom in on that? Can we get a little closer? Can we get a little closer on that?
That's our area. That's a little lighter, actually. It seems like the counties.
Well,
that's
Boone, that's Carroll. There's Boone.
Western.
There's Newton, and there's Searcy. So Boone is a little purple, but boy, look at Yellville. That's stroke deaths. That's stroke deaths. Okay. Get back out here on this. Whoop, there it was.
Could that be because we're making an impact? We're catching that, and we're getting better through time.
Well, Arkansas is still one of the leading places. Look down there in southeast Arkansas, right down there. and Northwest Missouri,
Yes, sir.
Northwest Louisiana. Real tough there. We are making inroads gradually, slowly but surely. We're making inroads into it, and that's what we need to do. And the AR saves people, and UAMS is some of those folks that are helping us get into there. Yep. So there's information for you. Um, there is all kinds of information out here, publications and research. If you click on that, you can see that there are toolkits out there, and there's science briefs, and there's policy stuff, and there's how to model, how to, collaborate, how you could do some of the things and this is an interesting one right here. I saw when I was looking at this earlier. This is pre-hospital transport times and the outcome after different reperfusion strategies. And this was talking about, this is us pre-hospital, um, what they found out, getting reperfusion and how EMS plays a part in getting the perfusion out there. Um, um, if the pre-hospital transport time predicts the choice of reperfusion strategy for STEMI patients, the probability of STEMI patients receiving primary PCI falls into the transport time to a PCA facility. So we're doing that. We are sending people to the right places. They're getting the patient to the capability and capacity they need. And pretty interesting stuff out there from the CDC. So you need to go out there and look. You need to go out there and take a look, see what you can get into and what you can look at. And here's a related site to the CDC. Here's this one here is the um, Surgeon General calls for action to control hypertension. And you can have controlled hypertension and non-controlled hypertension, and uh, you know all the things that come from that. And we can look at that at a later time. Okay, somebody sent me a chat. Okay, thank you, Regina. I got that. So we're going to stop sharing. So where some of these things where some of these places to go to get information and to understand stroke more than just listening to it. I would start with AR Saves is the first one, and that website is a treasure trove of information that you can get there from the AR Saves, and I like the MRI there they have, or the CT scan. They're looking there at it. Um, Stroke Programs Award, they give awards each year. If you need EMS resources, they're right here. Here's the participating hospitals. And if you look there on the map, they're just about everywhere. Uh, yeah, there you go. So we can see where the participating hospitals at. There are Blue Star hospitals, and there are Green Star hospitals, and there are spoke sites. And somebody was asking, yeah, um, Conway Regional in Conway, Faulkner County, is one of the Green Star facilities. Um, these are ICU capabilities. Wadley in Texarkana, Jefferson, St. Bernard's, Conway, and St. Vincent and Hot Springs. So those are good. Um, the spoke ones are the ones that, like we are, I think North Arkansas Regional Medical Center is listed there. Let me see. Uh, guess what? It's not. Okay.
North Ark was at the top of that other page.
All right. There we go. Yeah, we are a spoke hospital, and that gets you into a Green Star hospital, which has ICU capabilities, and then the intervention hospitals are the UMS Baptist Medical, Washington Regional, and Baptist Medical Centers in Sebastian County. Fort Smith was the first heart hospital. Okay, so what other EMS resources do we have? There we go. Training. And then they have, this is neat, learning on demand, learning modules, stroke toolkit, ARSA participation, stroke care, and the transport map, drive times to compute the center, and then the Arkansas Department of Health. Tim Vandiver is the lead person down there. And of course, COVID has kind of everything locked down, but you can do these EMS learning modules. And last time I was in here, we got this too. There's no activity, and that's because we can't get together and learn anything. Um, Titles A to Z, there's no activity. Relevance, there's no activity. So that doesn't help you a whole lot, does it? But yep, that is the learn on demand. And when you go back one, here you go. You can see the things that are out there that you can get into. And I don't see a whole lot of stroke stuff in here. There's the Power Workshop, Digital Health 101 for all professionals. Um, some of these are feeds, some of these are not. There's curriculum there. So learning on demand is a big thing now, and you have uh, the television guidelines are there by clicking. So you can go out there and get your 10 hours of your personal CEUs that you're going to need by going there. Let's see. You send Tim Vandiver a message and ask him if he's got anything. I don't see anything on the calendar over here. Stroke Toolkit, what does that look like? There it is, best practices. And this is from the Arkansas Department of Health. It might actually have, there's the information. Let's see if it's got any data. Y'all want to look at some data with me? Introduction to the BFAST stroke scale, stroke facts and figures, page 7. Let's go over here to page 7. Whoop, right there it is. Let me get this bigger so we can read it. 800,000 Americans experience a stroke. That's probably equivalent to one stroke every 40 seconds. Okay, ischemic, it's a brain attack, like a heart attack, except it happens in the brain. Clots can form. 87% are ischemic. Comment from somebody?
Wow, every 40 seconds? That's ridiculous.
That's in America, every 40 seconds. We are under pressure.
Wow.
Yeah, that gives you the scope of this. Betcha.
And that's the ischemic numbers?
That's the ischemic
or
number.
just in general?
No, that's total stroke experience. And of course, so if you want to, let's see, let me turn on my rusty trusty calculator, and if I do 800,000 times 87%, oh, that's just a mere 696,000 ischemic strokes each year in America.
That's a lot.
Yeah.
That's still.
Well, every 40 seconds, gosh, if you figured that up an hour, yeah, that's a lot. And then you take 87% of it as ischemic, which can be treated. That's amazing. Times brain.
A lot.
Yeah.
There's at least 60 people within, minutes wise.
Mm-hmm.
40 seconds, a minute, that's about 60 people per hour, give or take, even more than that when you start figuring in more and more seconds on top of each other.
Yeah. Look here, researchers have estimated the average brain has between 86 and 100 billion neurons. Neurons. These are the things, this is the functional part of the brain. A stroke occurs, the lack of oxygen can kill 1 million neurons, about 32,000 neurons a second. So the brain ages 8.7 hours per second without treatment. Brain ages 8.7 hours per second. So you get older with each second while you're waiting for that. Gosh, you could get old real quick in an hour. Okay, so there's a chain of survival. Got to detect it, got to call EMS, got to get to the entry level, got to get the drugs, and then got to go to rehab if it needs to be. Um, stroke patients to the nearest certified facility within 24 hours of onset. So there are stroke ready hospitals, these are AR Save hospitals, spoke centers, and those sort of things. They can get recognized. And this was, I don't know when this paper was written, but there is the practices. EMD receives the call, then we put it out. And door to drug, this was a question somebody had in the last thing we had, was what is the time from the door to them getting the TPA? The door to drug should be, for best results, 60 minutes. So when they arrive at the hospital, 25 minutes to CT, 30 minutes for coagulation studies, 45 minutes to interpret the CT, and 60 minutes to get the drugs in. So we got to have the scanner cleared. We got to call the code stroke, and we got to get them the medication as quickly as they can. EMS guidelines are there. There's the stroke assessment scale, and there is our what? Be fast. And they also want you to learn the Grosco Coma scale, which deals with motor, verbal, and eye. And you want to be able to read and get them in the right place. All right. This would be a good piece of information that you should have in your toolbox. I'm going to copy this and put this into our message, our chat box, okay? So y'all can be able to go out and look at that.
Perfect. Thank you.
And this will be available to anybody that wants to get it. Pow. There we go. Look at there. I have been taught how to do this. And this will be recorded, and it will be on the website someplace. So there we go. So that's that one. Questions, comments. This is the Arkansas Saves, and their resources are there. Their publications is there. So this is the Arkansas Saves for 2019. We've been looking at data. Let's look at this one here that has the Arkansas Saves data for 2019. That's pretty new. Usually you don't get statewide data out that quick.
On these data, this is Arkansas as a whole, is where this comes in to all the.
Look right here. Look right here. State capital, and look, you're sitting right there on the steps. That is.
I can't see that.
Oh, that's the mega brain. Hang on.
Oh, okay. Oh.
Do you see it now? See the mega brain right there? Yeah, that's a pretty awesome picture. And
that
go ahead, I'm listening.
Well, I was trying to think of a way to ask the question and all, so it kind of makes sense and all. I mean, I've got it pondering around in my head, but that's a squirrel brain for you. All these numbers and statistics and everything that they're gathering and the informations and all, what's the majority of those percentages coming from? Like, I guess the better way to put this is where I'm coming from is we at North Ark work in we don't work in no big metropolitan where we're just down the roads and streets and this and that. I mean, we've got to take considerations. We're in mountains. We're in curvy roads that take us forever, even though it's 5 miles down the road. It could take us several minutes to get there. You know, how are they basing all these percentages off of? And do they take these into considerations as far as they'd have to, I guess, but things out of EMS, you know, our control of things, even though we're trying now because of the circumstances of everything. I mean, again, we talked about earlier, no, we're just not working in the best of environments most of the time based off of our locations of how we operate.
Okay.
If that makes any sense. I mean,
sure,
anybody can jump in on that. I'm just.
It does. Look right here, North Arkansas Regional, Harrison. And I'd have to go back over here to read what the legend is, But that first part there is consults, TPA, and then, yeah, so let's look at that for us. So 56 consults in 2019, all right? TPA was given 24% of the time. Is that right? Yeah, 24% of the time. 24 cases, rather. All right. And the last number is community attendees. How much outreach did we do here at North Ark? Looks like we had 20,538. That is our numbers. Those are our patients. That is what we did here at North Ark, and it's down on page 16 of this page. I'll send this out to you again. Let me zoom back out, because if I zoom back out, you can see um, the median time targets door to drug was 62 minutes. The median onset of symptoms to the at a place has doubled. Arkansas Save has a 38% treatment rate. Total consults, they're up 1,300. Golden hour target, look at there, they're hitting about 48%. So, we're making a difference cost wise. AR Save has contributed $29 million to the cost savings and care of stroke patients in 2018. So there's their staff, and there's the mega brain again. So, this is Arkansas data. This data comes from us. We have sent this data in. So it is
Well, thank you for
good.
that. No, that's not, like I said, I'm not, sorry.
That's okay. Sorry, go
I
ahead.
was just saying, I'm not bashing by no means. I'm just saying we're here at North Ark, we are put with a lot of obstacles at times, and a lot of these folks that's before me and has been there a lot longer than me can probably contest it. I'd like to believe we do really well for the conditions we work in a lot of times, especially how far out we are with a lot of our calls. And it's just good to see that on paper, and you show the percentages that we're really trying, even though we're sometimes our backs to the walls on the circumstances and locations of calls too. So it's good to see that and to know that we're trying.
Here's an interesting news story that they put in their annual report. Oklahoman glad he was in Arkansas when he had his rare stroke. So this fella that was a police officer in Oklahoma City was on vacation visiting Arkansas, the land of opportunity, when he had his stroke over in Mena. And it was quick thinking of that staff that got him in and got him taken care of. If he had this stroke in Oklahoma, where they don't have an AR saves, don't have a stroke possibility, his outcome may not have been as good. So there you go. But yes, and you can go back as far as you want to. AR Saves has been around since 2008, and you can look at the newsletters they've got there, and you can read their data. And yeah, so that's always a good thing you can look at. Let me go back one. And this goes back to EMS training resources. We did that. And of course, there's online training, there's Institute digital help that you can go in. You want to go to work, there's jobs right there. See what the online training looks like. Uh-oh, something went wrong. I think if I go back, this is going to give me the same thing we saw a while ago, learning on demand. And you could just, use of management of marijuana, OB patients, escalating, it's a matter of life. And these are all courses that are there. And if you like some of this, you just have to click on it and go. And you can view all of them in this free online professional. I like the word free. You can get CEU hours for that if you find anything that you want to look at. Autism, anticoagulant study, epidemics, ethics, that would be a good one to do. Challenging of serving brain injury patients during a pandemic. Um, Outpatient joint arthroplasty, it's not for everybody. Working from home during COVID, managing stress. Stress causes hypertension. Hypertension causes strokes. There you go. extremity fracture, managing, moving the needle. Uh, yep. And you can go down through here. There's all kinds of classes to take there, and you need some 10 hours of personal training. So there we go. All right. Let me stop sharing, or am I not sharing?
You're not sharing anymore.
Okay. All right. That's okay because I want to go back out here and I want to pull something else up. But I got to go out to get it. Anybody else here besides me and you? Or is it just us'ns?
I'm still here.
I'm here.
Oh, okay.
No, I'm here.
Y'all about to talk me to death.
You just thought you was by yourself.
I was. I thought it was me, myself, and I, and the squirrel. I was supposed to pull this
I'm
up.
the only one that has a mouth.
So true, squirrel. So true.
But that's all right. If you don't ask, you don't know. And if you don't ask, you don't know, then you're quietly not where you mean to be. All right, there you go. That's not what I want. I want this. And, oh, I do have those. Okay. That's what I want to look at. And I want to look at which one? That's the latest. Good, good, good. Here we go. I finally got there. Now we're going to share the screen and we're going to talk about what we need to know as far as, get out of the way, this thing right here. That was not what I was supposed to show. Hit the wrong screen button. Sorry, guys. I am getting there. It's just taking me a little bit of time. My computer is running slow. I guess I've got too many windows open on it. And there it is. Now if I go here and go here, close. It's being hateful. It won't let me go there. And I don't know why. But that's all right. We will figure it out. Oh, there it is. How about that? How many of y'all seen this thing?
Looks familiar.
I have.
Some of y'all have helped write this thing. And that's good.
Not me.
Okay. Well, maybe we should. This one was updated March 2020, which is when the pandemic hit. And these are treatment protocols that have been signed off by Dr. Raymond Griffith, who is our medical director. And I thought we just might go out here and look at a couple of three protocols. One of them we'd like to look at is the one we're talking about right now with stroke. We can go to stroke first. And if you ever get on your PCR dinged and said protocol deviation, and then it'll give you a number. That number corresponds to this number up here, 14-18 is a stroke. General supportive care of a stroke, we'll have to look at that one. Airway breathing protocols, if oxygen saturation is less than 95%. Determine last known well time. Blood glucose, treat only if it's less than 50. Perform a BFAST for activation and documentation. Limit scene time to, we said 15 minutes a while ago, but looky there. Scene time here is 10 minutes or less. Contact the ER code stroke early so they can get the CAT scan cleaned up, get vascular access, obtain obtain the second IV if possible. 220 gauge IVs are preferred. You draw the blood per procedure, attempt to get at least a blue top blood, and look at there, obtain a 12 lead. That is the NARMC EMS's protocol for stroke. Now, that's the ALS protocol, by the way. Blood pressure elevated, contact medical control to treat the diastolic if it is uh, less than 120 or less than 230. Nitroglycerin may be contraindicated. Labetalol is the drug of choice. All right. All transport should be considered. Air transport should be considered if transportation is close to stroke center is 45 minutes. So 45 minutes is what we're wanting to get there. And it goes into the notes there. It talks about thrombolytic therapy has to be started within 3 to 4.5 hours. So that's one of the considerations for getting air medical involved. You need to make sure altered mental statuses should be treated first. That's your hypoglycemia, other things that may be going on that cause that. And the onset of symptoms is defined as the last witness time the patient was symptom-free. Awake with the stroke symptoms should be defined as the onset time and the previous night when the patient was symptom-free. All right. So do you know now what you're supposed to be doing for those?
It doesn't shut up.
You done shut up? Well, we need to get you back talking because I need
Yes.
to. All
I
right.
said yes.
Yeah, I heard you. I heard you. There we go. That's the EMS protocol. So I'm going to go back up here to the top because this is a basic class. So I'm going to look here and say, well, you may say, well, these are all ALS. Well, I bet you there's basic treatments in here too. There's your medications, protocol guides, vital signs. Yep, King Airway, procedure guidelines. Those are things you're going to do, and then your reference guides. This is in your protocols, and you need to be aware of the protocols so you'll be able to treat the patient in the proper way. So it said general supportive care. What does a general supportive care say? Well, it says conduct a primary assessment, airway, breathing, circulation. Yep, priorities, treat life threats accordingly, determine treatment priorities, rapid transport, stay in play, obtain a complete set of vital signs, blood pressure, pulse, respirations, SpO2, oxygen administration, and administer appropriate amount of oxygen. And you got to have 94 to 99. Secondary survey, when appropriate, exposing the patient as necessarily appropriate to treat those. Conduct pain assessment, conduct the 12 lead as condition dictates. And it goes on to these little steps right down through there. And the big thing is the minimum evaluation for vital signs include blood pressure, pulse, respirations, SpO2, and blood glucose level done as needed. And there needs to be a minimum of 2 vital signs on every patient. That is the adult general care. So we also talked about, hang on a minute, let me get back up here. We also talked about cardiac post-resuscitation treatment. There we go. We have a post-resuscitation treatment. And when you see something like this in your protocols, you can just about agree that this comes directly from the American Heart Association. And it is because this is their flow sheet. So that means we need to follow the ACLS mega code guidelines on these post-resuscitation care patients. So we need to maintain oxygen saturation. We need to consider advanced airway and capnography. Do not hyperventilate. That's important. We need to get an IV so we can give them fluid boluses. We might need to give them vasopressor. Dopamine's one of the big ones for that. And consider treatable causes. So 12 leads should be done for coronary reperfusion. Follow commands. Initiate targeting temperature management. And of course, we don't have that temperature management here. What treatable causes do we have? Well, we have H's and T's. That's for a later time period. Let's see. All postcode patients must be assessed for the need for intubation. If working a code on scene, rapid transport is needed upon ROS. So when you get ROS back, you really should transport the patient. And then dopamine's preferred vasopressor to infuse, but after the hypovolemia is ruled out. So we need to make sure that we get that taken care of. All right. What else? We've talked about strokes. We've talked about calling code strokes. Yeah. And anybody that wants a copy of this can get an electronic version by asking Chrissy. Chrissy is the keeper of this data, and it's good data to have. A good time to look through it and review it. Nope, didn't want to do that. You ever wanted to move into something and then you backed up and said, wait a minute, that ain't right? All right. Questions on strokes. I'm just about beat this to death. I'm going to go back up and look at the objectives and see if we've met this. Identify the options for out-of-hospital stroke assessment tools. What assessment tool do we use in Arkansas?
Air saves.
Which is BFAST, right? Why do we want to limit oxygen in a stroke emergency?
BFAST. Not told.
Yeah, you're here. I hear you. I hear you. I'm trying to wait for some of the others to come back in here. Hyperventilation, yep, which causes cerebral what? Decrease in cerebral perfusion. They're already decreased the cerebral perfusion because they're having a stroke. So that's not good for them. Give them too much oxygen. What happens down in the cellular level?
It releases the ISIS brothers.
Come on, get the right word for it. You're close, John.
Oh, the radical. Oh, dadgummit.
Radicals.
Radicals.
Yeah. It releases the radicals, and that causes damage to the cell. What is the importance about knowing the timeline for stroke events? Why is it important for us to know last seen well time?
So the correct care can be provided. You got that timeline for the TPA. So
what is it?
Knowing the time.
Go ahead. You're right.
Knowing the time helps with the TPA ability.
And what is the time?
The window. Time is tissue.
What is the window?
It's been a little bit changing, but between 4.5 to 5 hours, I think it is, or something like that. We was talking.
Mm-hmm. So,
well, we want to do it as fast as possible, even greater than that, so their time's even better and recovery is better.
Yeah. So, where is the most appropriate stroke hospital for these patients? And Todd, you can say it again.
For our area, you mean?
Yeah.
I believe Regina or some.
Cox Branson.
Cox Branson's AR Saves. That's one you need to go to. NRERMC is an AR Save spokes hospital, so they can go here.
Most appropriate facility.
Yes. The most appropriate facility. All right. Well, we're through with that. Let's talk about cardiac arrest for a minute. All right. And There you go. So there are 5 links in the adult chain of survival, right? Can anybody name those 5 links? And let me blow this up so you can just read it out loud to me.
What was the question, Casey?
5
Oh,
links
chain of survival.
in the
Okay.
chain of survival. Yes, ma'am.
You want me to go ahead and read it?
Please.
Immediate recognition of cardiac arrest and activation of the emergency response system. Early CPR with an emphasis on chest compression. Rapid defib or defibrillation. Effective and advanced life support. And integrated post-cardiac arrest care. Because we are going to achieve ROSC.
We are going to achieve ROSC. In fact, in 2021, in February, the new AHA guidelines will come out, and there will be 6 links in the chain of survival. Just a heads up. And the 6th link will be rehab, recovery. So they want this strong chain in place because this is what gets victims through the facility and into treatment and into returning them back to normalcy.
Okay, I'm sorry. A patient stepped up. As far as rehab, are they talking cardiac rehab, like a physical therapy type of stuff? Is that where we're going?
Yes, that's where they're going.
Okay.
Because they want to bring in the rehab people because they have that rehab to get them back to their normal life. That's what the chain of survival is. From the event, which is the immediate recognition, back to integration into the community. They want that total chain. And one of these days, it won't be a chain; it'll be a circle. I'm sure. If I live long enough, and the Heart Association continues doing its studies. So, strong chain gets us out, helps us with people. So, chest compressions. How fast do we go?
Somebody posted that answer. Like it says, 100 to 120 per minute.
There you go. 100 to 120 per minute. Push hard, push fast. How deep do I go?
On an adult, it's like 2.5 inch, and then if
2
you're
inches.
dealing with a
Yep.
child, I believe it's what.
But now, your adult is different from my adult. Okay, they push.
We're gonna go 2/3, right?
True.
1/3.
Okay.
1/3 of the chest.
1/3.
You're right.
I want to go all the way back through it.
It's all right. You push it on me. You push all the way 2/3. You go up my back.
All right.
Because I want you to give me a chance to get up and walk away. I won't ROSC. Okay.
All right.
It's 100 to 120. We want to push hard, push fast. All right. And they want you to use a feedback device. I understand that the monitors we have on the truck, the Zoles, actually have a feedback device on them. Is that correct?
Yes.
Do we use those when we're doing cardiac arrest?
I have.
Okay. And what has been your result from that?
It just, the feedback from it is automated, but it gives back, it'll let you know if you're pushing too lightly. If you're, I'm not for sure if it's too deep. It'll let you know about light and if you're not doing it fast enough. It's the 2 things I've heard on Audible from it. And anybody can step in, correct me if I'm wrong, but those are the 2 I have dealt with.
Somebody's coming. I heard them.
That's all I've heard it say. But for it to do that, you have to use the little pad that's
right
on there.
And the American Heart Association recommends that you use a feedback device. You can actually buy a little square piece that goes on the patient's chest that will measure your depth and your rate. And it has a metronome and it tells you you're going too deep, too shallow, too fast, too slow. But the feedback device will help you stay focused. I'm going to figure that they're going to come up with a way for a feedback device Somebody smart needs to come up with a feedback device that goes on an Ambu bag that will beep every 5 to 6 seconds. And that way you won't put in too much breath. Now, Todd, you want to make $1 million? There you go. I just threw it out there.
Well, it's not done that, but I have seen when they hook up to the monitor this what's the other piece called, the CO2.
Yeah, entitled CO2.
Yeah, if you push that on there, you can tell if you're giving breaths too frequently.
And you can also tell if you're not doing adequate compressions, because that entitled CO2, if you're not doing adequate compressions, the metabolism will be down and the CO2 that's exhaled will be down. So it's pretty neat stuff, pretty deep data that we can get back through some of these additional things we put on. But they have found and determined, ICOR has gone out, paid for research to be done, and they can say that the speed and the depth of compressions will be the determinant factor of returning for ROSC and good neurological output. And it goes with what they call a CPR fraction, hands on the chest, hands off the chest. And really, you guys that are working with paramedics need to understand that if we do a stop for a rhythm check and we see ventricular fibrillation, we want you to go right back instantly and start compressions. And I will tell you before I push the shock button, because we're losing time right there. Hands off the chest. Go back and think about this. How many times you've been in a code situation and they were checking a rhythm, or they're checking a pulse, or they're intubating, and they have held CPR for 5, 10, 15, 20, 25 seconds? I remember it. I've seen it done. I've done it. Guilty as charged. And when you hold out for that period of time, it just takes away from the opportunity for ROS to occur. So, we need to be cognizant of keeping our hands in the right place, doing CPR, and understanding even if we're doing the AED, once the AED says shock advised, go on and start compressions. And then before it shocks, make sure you clear, of course. So we want to make sure that compressions is 2 inches, a third of the chest, depending on the size of the patient. Don't compress any more than 2.5 or 6 centimeters, 2.4, whatever. And, what if you do press too hard? You're going to break a rib. Can a person live with a broken rib?
Yes.
Yes. Can you live if your heart's not beating? No.
Nope.
So you got to do that. And you need to allow for complete recoil. Remember, the heart fills when you let the chest re-expand. So don't ride the chest. That was one of the big things that they got me on when I did all this stuff. And we got mannequins now that tell you whether or not you're doing them good or bad. And you do practice with one of those tattletale dummies, recording dummies, to see how well you're doing it. Now, there is a relationship. And this may change down the road, because there are 2 breaths after every 30 compression if you're using a simple airway, all right, an advanced airway. But if you got an advanced airway in there, you count 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, bag. 1 breath every 6 seconds is what they're saying if you get the advanced airway in. What's an advanced airway? Anybody?
Intubation?
Intubation works, yes. I'm looking. I got some chat here. I gotta go look at.
I've seen that, Gina, your OPAs and MPAs. I've seen your text.
Yep. I understand. Thank you very much. Okay, so yeah, we the breath should take about a second, and it should ventilate just enough to see chest rise. Okay, So those are the things that we need to deal with there. Okay, so there we are. Now there are groups out there that do what's called pit stop CPR, and pit stop CPR is and I got a video on that. I think I can go out here and show you.
Hey Chase, can I say something real quick?
Sure.
On the you said, you know, where you had that pause in between the checks and stuff, and then we haven't gone back to CPR or chest compressions. I can speak for myself. You know, I've even made the mistake of doing that, and that's because you kind of get lost or focused when they say take that pause for a second, and you kind of, me for instance, I lose focus of going right back to it, even though it should be automatic. You kind of, for me, I lose the focus, like I just, oh crap, and then you go back to it and you're like, dang, and you don't. I ain't gonna say everybody means to do that. They probably don't, but that for me can happen, and I've had that happen to me before.
That's true. Very true. All right. I'm not going to watch one of these long videos, but how long is that one? Oh, that's too long. The other thing that we can have that will come involved with using the doing pit stop CPR, and also is use of a use of automated device to do CPR, and there may be a possibility that that may come out there and be there. So just be aware of that. All right, so let's see here. Stu. All right, this is the video on pit stop CPR.
The old way of CPR in the Wilmington Fire Department was usually that the youngest man on the truck ended up doing compressions. Dripping sweat doing compressions for 30 or 40 minutes, and you would never stop. The youngest guy on the truck was dying. He was exhausted from doing compressions. Trying to make your heart beat 100 times a minute by pushing on your chest. Our save rate has gone up about 9%. So far this year, we're at 24%, which is a huge number comparative to the nation. The nation is about still at 9.6. We named it the pit crew process basically because you're in the South and we like NASCAR. Like the pit crews on the NASCAR team, everybody already knows what job they're going to do when they come across the wall. Same way with us when we get off the fire truck. Everybody's assigned to a job. 2 more rounds and they hit the AED. No delay of care or delay of compressions, which is the most important part. 30. If the blood is not moving, the oxygen's not going anywhere. So you can breathe in and out of somebody all you want, but if the blood's not moving, it's not doing anything. Now. So when we walk in the room, obviously the first thing we're going to do is we're going to check responsiveness. Hey sir, are you okay? We're going to check the pulse. All right, I got a pulse. If they don't have a pulse, they're not breathing, we're immediately going to start chest compressions. One of the 3 guys, he's already going to be assigned compression, so he knows he just needs to start compressions. He's not going to do anything but for 2 minutes but do compressions. He has no other job. The guy that's kind of running the show is the guy with the AED. He needs to bare the chest so we can put the pads on. And the 3rd guy is at the head, and he's going to be doing airway. Put a king airway in, and then compressions never stop. 2 minutes go by. We turn the AED on. Analyzing heart rhythm. Well, the guy that was just doing compression is going to switch with the guy doing airway. The guy that's doing airway will switch with the guy that's doing the AED. Whoever's actually running the AED is actually taking a 2-minute break. Shock delivered. Because they're the next one to do 2 minutes of compressions. Quality of the compressions stays the same. We don't lose the effectiveness of the compressions, and it's better outcomes for the patient. After we implemented pit crew, first call I went on and we actually used pit crew, it was obvious afterwards that we weren't as tired. We actually measure the people who make it to the hospital, get well, and leave the hospital. Those are the only ones that count as a save for us now.
Whew. Sorry. I don't know if y'all heard that last little bit or not, but anyway, that's pit stop CPR, and that's in a that is, I'm trying to remember where it's at. It's in the south.
That is
Where?
cool. No, I just said that is cool. I was agreeing with you.
Yeah, I'm trying. I wish I could remember where it was, what service it was, but it was a fire department, and you heard their numbers have gone up by 9%. They've got a 9% save, so that is pretty dadgum awesome to have that occur at that level. So it's important to see that. And pit stop CPR is just that. Everybody knows what they're going to do. And I'm encouraging EMS people to get together with their partners. We talked about getting maybe ACLS for basics as one of the courses to come to education to run the non-advanced people through ACLS, so our basic partners understand what's going on and how to function in that team, because we are a team. It's just not me, the paramedic, running the show and you doing what I tell you, because I may get in the middle of code and I may be tired and I may have to look at you and go, okay, what should we do next? What's the next step here? But places that have pit stop, and they do this in Little Rock, MIMS does it. They'll send 2 trucks so they have an adequate number of people. That's something that we are precluded from here. But Taney County, they do pit stop up there. The supervisors run on theirs, and they become the ones that bring all the stuff in. First crew in does just CPR. The second crew in comes in and does the advanced stuff. And then the third person comes in, and then that goes on from there. And everybody is assigned a role, and they know. This fire department here used 3 people and just rotated among those 3 people around the person to keep good quality, high quality CPR going. And that's what this is all about. And places that have put pit stop in have seen their ROSC levels come up. Maybe we need to get with, well, if we do put in a device that does artificial CPR, then that would be something that we might put in. And that's where I'm at right now, is the mechanical CPR devices. Somebody has said that NARMC is looking at those. The old thing about those is they are just like putting an extra person on the truck. So,
As you know, working on ambulances and stuff, and everybody can probably contest, when you're just 2 people, that don't work as well. But we burn out probably quicker, because there's times you go out on calls and you don't have those extra hands. So anything that can help us, like what we're seeing, any whether it be mechanical devices or such, could gladly, and I'd like to believe, get everything back like it should. Greatly help.
Well, it takes somebody off the chest, So, we don't have to be doing CPR. We can just use their device. This is a video out of Canada, I believe it is. Yep, and this is the one that I understand. Let me get it up and get that first ad out of the way. Oh, it didn't have an ad on it. Well, I guess it's because it's an ad itself. I'm going to show you this video. Everybody ready to watch the video? Got some popcorn? About time for lunch, and we'll talk about that in a minute. Okay, got a black screen? This is 13 minutes. Here we go.
Lucas is a simple and intuitive portable device for external cardiac compressions. Lucas can be easily stored and carried in a backpack.
Cold manual compressions.
Backplate placed.
After the backplate is placed under the patient, it takes less than 20 seconds to stop manual compressions, connect the upper part of Lucas, and start mechanical compressions. In almost all situations, Lucas can provide effective, consistent, uninterrupted cardiac compressions in accordance with international guidelines. With Lucas providing compressions, rescuers have hands-free for other life-saving care. It can be used by ALS and BLS responders out of hospital and by code teams, cath labs, and emergency departments in hospital. Use it to treat patients following the same protocols as for manual CPR. Lucas allows for effective compressions during patient transport and safety for both the patient and personnel.
Now let's step through the basics of how to use it. The basic steps for using Lucas are: arrive, confirm cardiac arrest, and start manual CPR. Unpack Lucas and power it on. Assemble Lucas on the patient. Adjust and operate Lucas. Defibrillate and ventilate. Transport the patient. Lucas is very simple. This is the control panel. Here's the on-off button. Push it down for 1 full second to power on or off. When the green LED next to the adjust button lights up, you can adjust the suction cup like this to the correct start position for each patient. Use the pause button to set the start position for the suction cup. Press the active button for continuous compressions. This LED prompts you for ventilations 8 times a minute. While Lucas is operating, the pause button pauses compressions with the suction cup up at the start position you set. Active 30 to 2 does 30 compressions, then pauses 3 seconds so you can give 2 ventilations. Again, there's an LED to prompt you and also an audio signal that alerts you just before each pause. Useful. A couple of other things briefly before we move on. Make sure you don't cover these vent holes under here so it doesn't overheat. If there is a malfunction during operation or a problem that requires service, this indicator lights up red and you'll hear a warning buzzer. This button mutes any alarms during operation for 1 minute. But when Lucas is powered off, you can hold this button down to see the battery status. You should learn the various warning and battery status indications. They're all in the instructions for use. Keep it handy in the bag. What you're watching for is a red or orange LED here, together with an alarm signal. That means you have a low, empty, or defective battery. You need to either change the battery or plug in external power. To change the battery, pop it out like this and put in a fresh one like this. You can plug in the external power supply here if you're using mains or car power. But remember, the battery must be in position for Lucas to operate, even if you use external power. To minimize interruptions, always have a charged spare battery available. Okay, let's go over the operation steps in detail. Just like with manual CPR, when you arrive at the patient, confirm cardiac arrest and start CPR according to your protocols. If someone is already doing manual compressions, offer to relieve them. Now get out Lucas. Put the backpack down with the top towards you like this and open the bag. It's easy. Before you take Lucas out of the bag, push and hold the on-off button until it turns on. It self-tests, and you see the green LED when it's ready to use. Assemble it on the patient. Get out the back plate. Stop compressions briefly and slide it under the patient's back.
Stop CPR.
If there are only 2 of you, one should support the head while both of you lift the upper body. Lay the back plate below the armpits like this. Clear the patient's arms away from the back plate at these latch points. Keep doing manual chest compressions as much as possible. We're trying to keep up the coronary perfusion pressure and clean off any gel or anything slippery from the patient's chest to help Lucas stay in position. Lift the upper part of Lucas out of the bag by the leg handles and it springs open. Pull up on the release rings until the claw locks open. Okay, now click the closest leg onto the back plate. Keep fingers clear. Then stop manual compressions and lock in the other leg like this. Good. Pull up on both legs to make sure they are locked into the plate. That's very important. It's also important to make sure you position the suction cup correctly for effective compressions and to avoid serious patient injury or compromising the patient's circulation. Center it on the sternum with the lower edge of the cup just above the end of the sternum. That looks pretty close. Okay, you should be in the adjust mode. You can tell by the LED here. Use 2 fingers to lower the suction cup like this. You want the pressure pad inside the cup to touch the patient's chest, but without compressing the chest so it doesn't compromise circulation. But now we can see the edge of the cup is a bit below the edge of the sternum. We'll have to reposition the cup. Lift it back up like this and move Lucas by pulling on the support legs. Push the suction cup back down, and there, that's better. Hold it there and push the pause button to set the upper limit of compression. Now you can take your fingers off of the cup. It's important to press the pause button before removing your hand from the suction cup. But of course, when Lucas is operating, your fingers should not be on or below the suction cup.
They'll call you nubbin.
If you want, you can mark the right position on the patient's skin like this. With a mark, you can easily see if the suction cup shifts and you need to reposition it. What you're doing with the pressure pad is setting the upper limit of the compression. From here, it compresses down the same distance every time and then returns to this position. But if Lucas alarms with 3 fast signals when you try to enter the pause or active mode, then the patient is too small for Lucas and it will not be able to perform a full compression. Or, if you can't get the upper part around the patient and secure the claw locks onto the back plate, then the patient is too big for Lucas.
Uh-oh.
Do not try to use Lucas on a patient that it doesn't fit. It won't be effective. In that case, you'll have to continue manual compressions. In most cases, like this, it's fine. So let's do some compressions. Push the active button, and there it goes. You can see we switched over to a mannequin so we can show you full compressions. If you need to reposition Lucas, make all the adjustments as quickly as you can. Pause Lucas and go to adjust mode. Adjust the position. Reset the pressure pad. Hold it there while you press pause to set that position. Push the active button to resume compressions. Finally, we'll attach the stabilization strap. This helps keep Lucas in the correct position on the patient's chest. Put the cushion under the neck, up against the shoulders. Connect these buckles here and tighten up the straps a little bit. Make sure the straps aren't twisted and don't tighten too much. You just want to stabilize it in position. Don't over-tighten and pull it out of position. If you're in a situation where attaching the stabilization strap might delay or impair treatment, then don't put it on or put it on later. And as a more general warning, if there is a malfunction or the compressions aren't sufficient or something unusual occurs during operation, you should stop Lucas, remove it, and do manual compressions. Okay, defibrillation. You can defibrillate a patient without removing Lucas. Make sure defibrillation pads are adequately adhered to the patient's skin. Make sure no pads or wires are under the suction cup. If you arrive and the patient already has pads on, you might need to replace them or reorient them. During a rhythm check or AED analysis, you'll need to stop compressions. Push the pause button.
Analyzing now. Stand clear.
Make the interruption as short as possible so you can continue CPR. Use your defibrillator according to its manufacturer's instructions and your protocols. After the shock is delivered, verify the suction cup hasn't moved out of place. Readjust it if you have to.
One of the neat things about that, they were able to defibrillate that while the compressions continued. Did you notice that?
Push the active button to resume compressions. If you are ventilating with a bag mask, use the active 30 to 2 button. After 30 compressions, Lucas pauses for 3 seconds to let you deliver 2 breaths. Then it resumes compressions for 30 more. Once you have an advanced airway, like an endotracheal tube in place, you can switch to active continuous mode and deliver ventilations without pausing the compressions. When you transport the patient, you can secure their arms with these straps. This gets their arms out of the way while you work. Push pause to pause compressions while you're lifting the patient. At least 3 people should lift the patient and Lucas. Remember to support the patient's head even with the stabilization strap in place. Do not use the arm straps to lift the patient or the device. During compressions, make sure Lucas stays in the correct position and angle on the patient's chest. If this is not possible, push pause to pause compressions. As soon as the patient is horizontal again, check the position of the suction cup, adjust it if you need to, and push active.
Position's good. Check placement, turn back on.
During ambulance transport, the patient and rescuer should be secured. Just like with manual CPR, it's common for the patient to have bruising and soreness of the chest with the use of Lucas. Here are two other important procedures you need to know. If you need to change batteries while you're using Lucas, push pause, swap in a charged battery like this, and push active once you see the green LED here. Lucas can remember its settings for up to 60 seconds during a battery change, but if it takes longer than that, you'll have to readjust the suction cup on the patient's chest before you resume compressions. The same thing is true if you switch over to external power. And remember, you always have to have a battery in Lucas, even if it is plugged in. It won't run without a battery in it. Here's how you remove Lucas. Detach the stabilization strap. Push the on-off button for a full second to turn it off. Disconnect the upper part from the back plate with the release rings. Remove the back plate if the patient's condition allows. Clean Lucas as necessary before putting it back in the bag. Do not immerse Lucas in liquid because it can be damaged if liquid enters the hood. To change the suction cup, peel it off like this and throw it away as contaminated medical waste. Put the new one on like this. Make sure it's fully seated. Replace the battery with a fully charged one. Put Lucas in the bag like this, along with the stabilization strap.
Always put your toys away.
And that's basically it. Here's a quick summary. Arrive, confirm cardiac arrest, and start manual CPR. Unpack Lucas and power it on. Assemble Lucas on the patient. Adjust and operate Lucas. Defibrillate and ventilate. Transport the patient. Remember to read the instructions for use for information on cleaning, routine maintenance, and other important details such as general warnings. Thank you.
Okay, so we pause for a moment to get your opinion of this device.
I like it. It looks like it'd be worth to have. Maybe no. But if I understood that correctly, you replace that suction cup after every use from the look of it, or what I gathered from it.
Yes, it is. That's a disposable item.
I like it too. They look like they would be very expensive.
$15,000.
Cheaper than a cardiac monitor.
It's cheaper than another EMT on the truck.
Well,
yeah.
And one of our cardiac monitors.
Yeah.
Casey, that's terrible.
I know it's terrible, but hey.
It's not nearly as personable as another EMT on the truck.
Yeah.
And an EMT, you can tell what to do. That Lucas ain't going to listen to nothing.
It comes in a fashionable bag. Isn't that bag pretty?
Oh, my goodness.
Hey, the first time I saw this, Lucas, the hands were up on the side of it, and I thought the patient was holding the device on their chest. Because from a distance, that's what it looks like.
Okay, Casey, that's really funny, and it doesn't surprise me at all.
Yeah. I see there's a physio control one for $26,000, a Lucas for $15,000. I can buy a training unit to train with Lucas for $10,000. So if you got an extra $10,000, you want to buy a training unit for the college, they would appreciate that. Yeah. So there you go. Did it use a tank? Did I see a tank with it? Is that the compressed air that goes with it?
I don't know. I was confused on that myself. It looked like they was hooking up O2 to something or a tank to something, but I don't know if that was part of Lucas or we just caught them doing O2. Your guess is as good as mine.
I do not see when I go into some of these sale sites to where they sell this stuff, I don't see that it comes with a tank, a battery pack, a unit, a back plate, carrying strap, 90-day warranty. Yeah. So obviously that was not it. So there you go.
For a $15,000 device?
Yeah.
90 days. They're real generous.
Maybe that was a refurbished one I was looking at, Todd.
I would hope so.
You get a longer warranty of that with an EMT, don't you? Sorry. Now I'm talking rumor. Rumor has it that this is a device that may be out there being looked at. So there you go. And oh, I thought you could rent these things. Oh, by the way, they do have a finance plan for this. You can finance them for $440 a month.
Great. Let's get started.
Yeah. But, there are 24,000 of these in use today. Wow, that's pretty good. And more 15 years of experience. Well, they've had them out there for a long enough time. It should be time for us to kind of look at that. I worked with a thumper, and those things were terrible. They took a lot of working. But, yep. Okay. Questions? I am just about, by the way, they give you free shipping for anything over $99. So you don't have to pay the shipping on it, Todd.
That's probably every product they sell.
Well, yeah,
I
15,000.
The suction cup costs $99.
Oh, I was going to look for that.
Todd, you're probably right.
Hi, Gina Ray.
Hi, Gina.
Now you can say hi. Hello.
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 I don't see those. They sell cleaning kits.
Gina, would that be, what kind of sore are we talking about? Like a rash type or what? Got it. Okay. Thank you.
Are y'all texting? Because I have to get out of this to see the texting.
Virginia was sending some text to us and all, saying they're good products. Just I guess she saw somewhere where it can cause a sore on the chest area.
Well, you're dead. What's a sore among everybody? Is Gina here?
A sore would be the least of our problems.
Yeah. Oh, Regina. Okay, there you go. All right.
Yeah, she's here.
Okay,
yeah, sorry, I say it so fast it probably comes out wrong. I'm sorry.
It come out as Gina, and I was going to wait. Wait, she wasn't on my roster. Okay, so there we go.
Gina? Gina
right.
says she needs module 1.
Okay.
Okay. Yeah, Gina popped in. I caught her. Oh. And she said, "What are you doing?" I said, "Module 1." She's like, "Ooh, I need that one." She gone now.
Gina Ray?
Yeah.
I don't see her on this list. So there you go.
Anyway. I don't know. I just ran into her in the hallway.
Okay. Well, there are some NCCP day one things out there on the website, so you can go out there to YouTube and find these too. So there you go. Okay. Well, I need to close some of this mess out because I've got too much open. Don't save. There we go. Gosh. we're getting down pretty close here to the end of this thing. I'm thinking if there's me, we'll go back here and quickly review to make sure that we know what to do. This is cardiac arrest that we were just finishing up. And it says here the chain of survival. Y'all know that there are 5 parts to the chain of survival, right? You know there's a difference in 1 and 2 rescuer CPR. 1 rescuer CPR, you do 30 compressions and how many ventilations?
60 or 2. I mean, sorry, compressions.
Yep. And then if you're 2-person CPR, you're doing 30 compressions to how many ventilations?
Still 2.
Good. And the only thing you change is if you get a advanced airway. An advanced airway is anything King, ET, that's an advanced airway. And then you're doing constant CPR and you're ventilating once every 6 seconds. And your demonstration of CPR, which is the other objective you got to get done here, is with your card. Everybody's got a current CPR card, right? I hope so.
Yep.
Yeah.
Yes.
Yeah. Okay. All right. You guys got to quit this texting back and forth because I can't see it unless I come back.
I think that's text to you mostly because of the fact of a few that can't be on the speaker.
Okay. All right. Yeah, I see it now, and that's fine. But I got to come back to this screen to see it because when I have the other screen up, that's off to one side, and then my little bitty guy here turns orange. So there we go. All right. Now, this is the next thing. We got a couple of more things we need to do before we finish today. And trying to get it from 8, we're straight through to almost 1. We need to do a couple more hours. Do y'all need lunch now or do y'all want to continue right straight through? I will do what y'all say.
Say hi to Joe.
I would like to go straight. Would love to eat.
My phone's going dead, so I'd like to take a lunch so I can charge my phone.
My metabolism's burning. I like a lunch too. Squirrel's going nuts.
There's 2.
Well, it's my phone's going dead.
Okay.
And I'm not in where I can get charged it right now.
Jamie, take
no,
a
it's
break.
Stacy.
I know that's Stacy.
No.
But
Sorry.
I was looking at Jamie going, take a break or not take a break?
Well, if we don't, then I'll have to just catch up with you when I get my phone charged back.
Well, I'm just waiting to hear from these people. Go ahead.
I'm on a lunch break now, so now I can actually participate. But I mean, I'm listening and doing what I can. So I mean,
and
if
I
everybody else
appreciate
needs
it.
a break, but my
Todd,
phone is
I think
going
those
to die as
look
well.
good in that.
Todd, how about you? Break or not break?
This is a 2X too.
How much longer have we got to go, Casey?
About 2 hours.
I don't.
What do you think?
Okay.
I'm going to have to charge my phone.
Why don't we take a 30-minute break? 30-minute break.
I ain't gonna be able to change
30 minutes.
Yep. We'll be back here at 1 o'clock. 1 o'clock. 1 o'clock. Thereabouts.
See you at 1 o'clock.
Yep. I'm gonna
See you at 1 o'clock.
I'm gonna stop the recording. Let's get started. We're back together here. Those that are here. I see Jamie, John Rowe, and Todd Parker. And we're going to go out here and share a screen. Of course, y'all knew that was coming, didn't you? Because that's the way we do this. And we're going to look at EMS operations under the branch called EMS research. Did you know that 19 years ago, the national EMS research project agenda came out? And there it is. And it came out December 31st, 2001. And now that will be 19 years ago. And it talks about why we need to have research. Why do we need to change the culture of EMS and look at research? And research is what's going to drive the future of EMS. So That was one of the things. And then there is a course handout here, and this one is safety in numbers, and this comes from the National Highway Transportation Safety Administration, who is the guys that is over us as far as EMS. And I'll send y'all this one here in your chat room, and that's a good one. And this come out in 2014, and it is a grouping of information from the National Transportation and Safety Administration. Hang on, I'm trying to get there. There we go. And okay, where is it at? Let me stop sharing just a minute so I can get that. There you go. I couldn't get to where I could send that. And John, if you want to look at data numbers, this would be a good one for you to look at, because there's a little triangle right down here in the corner. Let me see if I can get it blown up. It's pretty interesting when you look at it, because it says there are 21,283 EMS agencies in the United States running 81,295 ambulances. There's 826 EMS professionals, of which you are one, and there's 28 million times EMS is transported someone in the year, and there's 37 million number of times EMS responds. So, if you look at the numbers that North Ark has been looking at, how many times we go out and we pick up or don't pick up, there's about 11 million no pickups in the United States each year. Just an interesting fact. Um, Transported motor vehicle crashes, states that have adopted EMS data collections. Arkansas are one of those. And then there is all sorts of things on how data saves lives. I'm trying to think if there was anything else on here I wanted to do. Saving lives together. And this all comes from a website. And here is the website I want you to look at. It's ems.org. If this is not one you're familiar with, you need to get familiar with ems.org. What? I don't think that's what I wanted. ems.gov, excuse me, ems.gov. That looks familiar. Okay. And COVID-19 information is there. They also have traffic technology transfer systems, strong support of EMS among public fields. The 2019 annual update. This is where I get my information on cardiac runs that we put into our monthly reports. Evidence-based guidelines in EMS. We talked about how evidence-based medicine is what we're going for, and you can read that report right here on this site. EMS and the opioid crisis, learn about opioids and how that is. CPR Lifelinks, high performance CPR program today. This talks more about pit stop CPR and some of those things. And your role in preventing heat stroke fatalities. So they're saying act fast if you see somebody in a hot car. Now, they strengthen the emergency medical service. They have an education section, workforce section. And by the way, under education, you can see they have an EMS Agenda 2050. What are we looking at down the road? We're in 2020. If we make it 30 more years, what will EMS look like? They have the agenda for the future. They have the standards and guidelines, scope of practice model, EMS core contents, and additional stuff that has been saved in there. So you can go in and look at all those things. And some of those things is pretty interesting. And this is the AACN training course for EMS and 911. This is their website. You can go in there and do that. We're involved with other initiatives too that's out there. One of the ones that I go to quite often is one that is called, hang on, let me go back over here, is NIMSIS. There it is, NIMSIS. This is the National Emergency Medical Service Information System. And I can go in here and I can pull reports on how many stroke victims they have and how they've run on it, what they've done about it. And it takes you in there and you can do some looking around and see what the numbers are showing. So Research is important. There's EMS data research here, um, and EMS data use video. This is a 2-minute video that shows why it's important. And let me see here if I can read more. There it is. Hang on a minute. I'm going to play you a video.
You know that documenting patient care is important, but often it feels like you spend more time completing paperwork than caring for patients. Accurate EMS data makes a big difference, not only for the health of your patients, but also for the health of the EMS system, which can be easy to forget when you're completing another PCR in the middle of a busy shift. Every day, you see that the information you enter in each PCR is crucial when transferring a patient. Doctors and nurses look at that record several hours or even several days later to help make informed decisions about caring for your patient. In addition, that record serves many other purposes thanks to collaboration at the local, state, and national levels to standardize and improve EMS data collection and use, and ultimately to improve patient care. Locally, data from your system's PCRs are used by your agency to assess and improve operations and clinical performance. Accurate patient records also mean your agency is reimbursed faster, allowing you to have the tools you need, from new equipment to safer ambulances. This information is also used to make policy decisions, like the need to designate a trauma center or more grant programs to support local EMS providers. And public health officials can use EMS data to identify trends in injury and illness to help make communities healthier and safer. Since all EMS data are collected using the national standard, millions of EMS records from across the country can be used to determine what helps patients the most and what doesn't. That research is the foundation for best practices and evidence-based guidelines, which help your system create effective protocols. Protocols that you use to provide safe medical care and ensure the best outcomes for your patients. Better information leads to better EMS and better care for our patients and communities. Visit ems.gov to learn more.
Oh, wasn't that fun? I thought y'all might enjoy that. Data is where it's at. I did not always believe that, but yep, it's kind of got that way. So um, all of the EMTs and paramedics and advanced EMTs at North Ark is going to start going through a survey, a research into how to write PCRs better. So that's coming. So beware of that as you get forward and look forward to things to take part in. All right. Nobody else has joined us. Have you been through that PCR training yet, Todd? No,
No,
it's
not.
yeah, it's about 5 hours. It's all online. You watch videos and then you take a test and you become a certified PCR writer. And it's not a bad thing. They haven't got to me yet either. So there you go. All right. What happened to there it is. Okay. We're about through. Hang in there. I'm looking for my research. Where did it go? Shoo. I don't know. There we go. I think I took that lunch and I ate my lunch and I think it scrambled my brain more than it already is. Uh, so I can't get back on track here. But there is safety in numbers. That's the EMS data. That was the handout that I sent to y'all in the thing. There's another thing out here called cares in action, and we'll look at that as we get down there through it. We need to identify national initiatives and resources that promote and enable EMS research. I already told you a couple. NIMSS, there is one out there called EMS 2.0, and there is the Agenda for the Future 2050. That's where the data goes. Your PCR passes through so many hands. It just doesn't go through from your hand to the hospital, but it goes from your hand on into your local facility at NARMC EMS, and then it goes on to state. The state gets a copy, and they process data, and then state feeds into NMSIS, and NMSIS gives us national data. And that goes back to best practices and coming up with evidence-based guidelines. So research is very, very, very important. And these are the national initiatives that promote EMS, because we want to have evidence-based medicine. We want to have the best care, you know. And with this pandemic that was started up way back there in February and March, that pandemic, some of the things that I was listening to on those websites, the website, was the fact that the Ebola project was the one that was coming up with this, and they were actually doing these things, getting ready for Ebola, but because COVID come in, they were able to switch from Ebola to COVID, and then they were able to reach out with evidence-based medicine. They were sharing, they were collaborating real time in the early stages of this. In March, when I was listening to them, they were coming up with, well, how about the prone technique? How many are using the prone technique for taking care of COVID patients? And this is where they were actually rolling the patient over onto their stomach. And some of these agencies went out and developed videos to show how to take an intubated patient, put them prone. Because for some reason, they were finding prone patients were doing better than patients that would lay in the bed on their back. There was other things that come out of it. Reverse Trendelenburg, where you raise the head instead of the foot, flip them upside down. They were doing all kinds of interesting things, but they were doing it through evidence-based and real-time modeling. And it was really quite exciting to watch the American health system and EMS roll out and start doing some innovative things. Seattle Fire was on there, Phoenix was on there, LA County was on there. There were a lot, and New York City's EMS guy was on there. And they were all talking about how they were dealing with the COVID situation in their community. And that was back in March. I haven't watched one in a few months, so I may be going back in and watching some more and seeing how it has changed. Because right now in EMS, good, bad, or ugly, we and in hospital and medical situations, we are kind of getting tired of COVID. Okay, it's run its course, it's doing its thing. We're tired of it, and the people are not wearing their masks. They're not social distancing. I just got a text from the Centers for Disease Control on my phone that announced that Thanksgiving should not be celebrated with your extended family. It should be your people in your house, and that's it. Don't bring people in. So they're saying put Thanksgiving on hold. Christmas is going to be on hold. They said if we don't put it on hold this year at this time, next year there may be an empty seat at the table. And that drives the point home very, very, very clear. Okay? So there is a group out there that runs that ems.gov that I showed you. ems.gov. That group that runs that is called FICOMS. That's the Federal Interagency Committee on EMS. Who all? Let's do this right quick, if I can. Are we still live on the camera here? Somebody grunt. Let me know what's going on.
Yes.
Okay, thank you. I'm going to admit somebody back in. Okay. So if you go out here, you can see this is the Federal Interagency Committee on EMS. Who is in FICOMS? Well, the members of FICOMS is the DOD. It is also the Department of Health and Human Services. There's the Department of Homeland Security. There is the Federal Communication Commission, and there's the Department of Transportation. And these people are FICOMS. And FICOMS meets and decides what we're going to do. And if you want to, you can go in and learn when they meet, and you can go in and listen to them. There's even reports down here that FICOMS does, and they have to report to Congress each year about their activities as far as EMS. And they've got their memos and everything right there if you wanted to see that. You can click right there and receive email updates from FICOMS. So this federal committee gets together And the Department of Transportation, that's where we're really under. But these other agencies say, hey, we have a part of you too. So EMS answers to all of these. There has been a move from the National Association to put us under this one right here, which is the Department of Health and Human Services, because they are the ones that's involved with trauma. Can you imagine DOD? That's the military people, and then over here, Homeland Security. Some people say, well, we should be in Homeland Security because that's terrorist attacks, natural disasters, and other emergencies that go on. But that's really not where we belong. And how about the FCC? Well, they deal with communications. That's it too. But Health and Human Services more makes argument that we should be there. But we are still under the Department of Transportation and have been under the Department of Transportation since the 1960s. So it's kind of hard to see us ever going somewhere else. And this website again is ems.gov. Click over here on FICMS, and you can sign up for their emails. Now there's another group that there's in there, and that's the National EMS Advisory Council. It's better known as NMSAC. NMSAC is a group of public people that get on there and they do comments and meetings and they make recommendations. And here are the NMSAC people. Do you want to see them? They're a bunch of suits, talking heads. Um, I'm sure some of these guys may be EMS, but a lot of them I don't see any titles behind them. But those are the NMSAC's people. And they have steering committees, adaptability and innovation, equitable patient care, technology, preparedness and education, professional safety, and sustainability. They want to make sure that we're able to sustain. And I'm sure one of these folks here belongs to an EMS agency. And I guess if you click on them, you can see who they are. That's tribal EMS. That one there's emergency physicians. There's a trauma surgeon. There's a local EMS administrator out of Arizona. A dispatcher. How about that? Got a dispatcher. Private EMS out of Portland. EMS educators. That's Mary. Kathleen here. She's a pediatric physician. Just looking. And there's an EMS practitioner. There is a manager. There is a management. Consumer. They even have consumers on there. There is an EMS. And on we go. EMS director, fire-based EMS, EMS quality improvement, and EMS researchers. There you go. But there's another group that deals with keeping us going and moving forward. So that's FICM. That's the other bunch. National Transportation Safety Administration has developed some guidelines. They issue out edicts every now and then to allow folks. Okay. And they use this practical research here. Now, CARES in Action, welcome. CARES in Action is a website that deals with CPR. And I forgot what CARES means. And here it is, Cardiac Arrest Registry and Enhanced Survivability. And they have many case studies. And there is Contra Costa County, California, Minnesota, Nevada, Colorado. Now there's another place it's really a rural area, and they have their studies here. And this is the CARES Act, and they gather data, and they work on their data, and they do their presentations, and then you can go through here and look and see exactly how they did their stuff, and how the CARES Act works. And they got a lot of data that shows that the CPR, pit stop CPR works. It shows the other parts worked, and it shows that doing it to the right level will enhance our abilities to actually be able to get out the patient and get more ROSC. I'm hurrying. Demonstrates the value of EMS with reportable outcomes. That's what we're looking for, is those reportable outcomes. That's why it's so important for us to do the monthly reports for stroke and cardiac. We may be adding trauma and some other things. That's why it's so important for NARMC to have someone read the charts, 25% of the charts, to see what is our reportable outcome. We know that we need to get out the door within 2 minutes. We know that we need to do certain things when we get there, because there are folks out there that are very litigious. They want to sue you, and if they get an opportunity to get a hold of your charts, they could possibly come up with a way to sue you. So 5 years down the road, we don't want you to go into a deposition and be handed your run sheet, and you look at that and go, well, I don't understand why I said this here and mark that there. So the narrative has to balance with the drop down, and the drop down has to balance with the narrative. So we need to encourage accurate and complete documentation. And that's kind of what we're doing for here. So how does research work? Well, research works this way. You got to ask a question. Anybody got a pressing question?
About research?
No, about EMS.
A question about EMS?
Yep. Is this Regina?
Mm-hmm.
Okay. Regina, what level are you?
I'm just a basic.
You're basic RN though, right?
Mm-hmm.
Why can't basic EMTs put in King Airways?
Because it's more in the anatomy, and it's not a basic thing.
Okay. You got to play
An
with me.
advanced,
You got to play along with me here just a minute.
Not for Arkansas, it ain't.
not an advanced EMT.
You're not an advanced EMT, but how do you put in a King Airway? Tell me.
Well, you just slide it in there.
It's a blind insertion. Do you have to know anything about it? Except when you bag with a King Airway, you need to have what occur?
The chest rise.
Good. That's it. So why can't basics put it in? Can't basics tell about chest rise?
Well, you'd hope so.
Yeah. So this is the question. This is how you do the scientific method. I'm asking a question. Why can't basics put in King Airways?
I see.
That's the first step. The second step is to do a literature study. So here I got to go over, and I'm going to try to sneak over here and do it this way. There we go. Y'all see my Google search? So I'm going to go basic, B-A-S-I-C, EMT, King Airway insertion. Look at there. EMT skills. There's a video for it. But I don't want that. I want, yeah, we'll just do that. So if I look at here and look, there is a national registry, insertion of a supraglottic device, failure, competent EMT inserts it. How about that? Here's one, and you do a literature study. You go out here and you look for stuff. Look at there, King Airway for BLS, first responder for rural administration. Now, who did that? smchealth.org. Okay, that's not Wikipedia. So that's got to be a good group here. Here's the Resuscitation Journal. Looky here. This is for intermediates. I'm not interested in that. I'm wanting EMTs. Okay, how about this one? NM.org. That must be New Mexico, maybe. But you go out here and you do the literature research and you start reading these articles, and it's going to open when it's done. There we go. iGel EMT airway updates. There is the iGel. That's a funny looking thing. And we'll replace the King LTD. How about that? And there's new procedures. And this is a slide presentation. And there's lots of data here, it looks like. And we can go through that and look.
Lindsay came, like they page and literally walk through the door and they have a situation over and try to get someone to buy a pack.
You need.
Okay. But anyway, you do the literature study. This wasn't what I was wanting, but it'll work out all right too. I might ask the question. Let's do it this way. What states use King Airway for basic EMTs. Now I'm going to go here and I'll just do that. We'll see what states do. And it may surprise you.
Arkansas ain't one of them.
Arkansas is not one of them, no, sir. There's an EMS article there, an EMS World article. There is a Kern Public Health, a pilot study of King Airways. Oh, look here, NCBI. That is the national. Yeah, this is a government website right here, International Journal of Emergency Medicine. A pilot study of the King Airway for use in Iowa.
I'm still here. I just have to go take a patient, but I have my headphones and I'm listening.
Okay, because we're gonna answer this question a little bit. And 2003, gosh, that's 17 years ago. They said they should put it out there.
Your voice is cutting in and out, Chase.
Okay, is that better?
Yes, sir. It sounds a lot better. Thank you. Sorry about that.
Okay, all right. And look here, they had about 13 cases, and they did the study. And here is their conclusion. As I told you, when you're looking at research, you always read their idea on it, their introduction, their parts, and then you go down to the end and you read their conclusion. Although the pilot project is small, it emphasizes the need for additional rapid airway management adjuncts given the number of ET failures from the above initiative. Okay, and this was an ET failure, so this was not what I was wanting to see. This was not the right one. But you know, I'm doing this on the fly right now to kind of give you an idea. Okay, here is one. This is the EMT Life, and the question is, what types of airways can EMTBs use in their scope of practice? And it says, depending on where they work, most places EMTBs can use OPA and MPA. However, in some locales, for example, King County, Washington, they allow OPA, only allow OPA. In other areas, they can use the King LT or the Combi. It just doesn't say where. So we might could get in touch with state health department and they can tell us which one works where. And yeah, so that's how we would do the research. All right. We ask the question, conduct the literature to seek answers. Then we determine hypothesis. My hypothesis for this would be rural basic EMTs using King Airway would have a high degree of successful resuscitations by putting those in. Now, I'm saying big things because first you got to put the King LT in, and then you got to prove that you have successful resuscitation, which is also going to be measuring your compression rate, your quality, and all those things. So you come up with a hypothesis. You might want to just bring that down. Rural EMS guys in Arkansas, or I could just say rural EMS in Boone, Marshall, and Newton counties could drop a King Airway to have successful ventilation of the patient. That would be easy. And then we would have to petition to state health to get an approval to run this study. And we might run it in conjunction with another rural service, maybe with Magnolia EMS down in southern Arkansas. So you get a southern and a northern, maybe over an eastern Arkansas service, and we all come together and we do the study. And then we test the hypothesis. We gather the data, and then we either prove or disprove our hypothesis. Hypothesis is nothing but a guess. And then we think about limitations. Then we report the finding, discuss the limitations, and then for good research to be good research, it must be repeated, adjusted, and redefined, and then you begin again. So research begets research, begets research, and it's an ever circling thing. But in the end, it helps drive evidence-based medicine. And that's what we need to do. Now, not that I'm going to do that scientific method for that question, but that's just one question. There may be other questions you have in EMS. And somebody somewhere said, Why are we putting C-collars on patients that really don't need it? Why are we putting patients on spine boards when they're getting and developing pressure ulcers? Somebody asked a question down there, and they went in and they did the research, they did the literature studies, they did the thing, they developed their hypothesis, and then they proved what they had. So now we don't use spine boards anymore, hardly. So this is how research comes about, and research is good for the services. Research is good for 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 EMS. So we need to have good research out there. Okay. Comments? Questions? Y'all are being quiet.
Now doing King's Airway or a skill that we've been taught even as EMT basics and all, it would be nice to learn and use those credentials versus having to be taught them and then told we can't use them. So I could play the devil's advocate and go, then what's the purpose of teaching us, no matter if it's national or not? If state can dictate and tell you not to, then why make everybody learn it just to be told you can't use it? I think that's a waste of our time, instructors' times, and just even funds to teach something that won't be used.
Well, Squirrel,
So,
Squirrel, everybody doesn't stay in Arkansas. They take the training here. They could go off to Missouri, and I think I understand. Somebody told me that superglottics are in Missouri. So, that's
Are
why
we
we have.
talking about the? Are we talking about the use of backboards and C-collars?
Well,
or are we talking about a more generalized?
We're talking.
I guess I missed that.
Okay, what we're talking about is how did we come about taking the backboards off the truck? Somebody did the research. Somebody pulled a question. Somebody developed a hypothesis. I was throwing out there the King Airway because I'm of the camp that says basics should be able to put it in. It's a blind insertion. It has chest rise. If you can do a bagging and see chest rise, then why can't I give you a King Airway and let it do chest rise? And it is research. This is how we grow in EMS.
Well, I guess I was just going to address what John said, and he's asking why are we trained on something that just to be told that we can't do it? And if we're talking about backboards, it's not a matter of you cannot backboard somebody. It's more a matter of you don't backboard everybody, but unless they meet certain criteria. So we do need to be trained because there are instances in which you may use this stuff that, because I've not been told do not ever use a C-collar or backboard on any patient ever.
I was talking about King Airways, actually. I just never got to, you probably didn't come in when I said I was talking about Kings.
Okay, I got you. That's where I was. But here's the thing is that, sometimes in an emergent situation, just, you're trained on it. You're trained through EMS with that, maybe our service or a different service, because when crap hits the fan, is there going to be a time when I might say, John, I need you to drop that King? I mean, what if I fall over, and somebody's got to take care of that patient? I mean, knowledge is not a bad thing.
No,
whether you're using it or not.
Right, and you're absolutely right. I don't deem or knock the fact of knowing it, because you're absolutely right. In a circumstances, we may have to take charge. You're absolutely right. I'm just getting at, it is frustrating to learn those valuable key assets, and then, at least for now, here in Arkansas, be told you can't use them, and then also that refresher of training and the knowledge of that, you kind of almost lose unless it's something you're continuously trying to train on, like you would do our CPR and those research and stuff. So it's, I completely agree, and I love knowing that knowledge. It's just since we don't get to use it, a lot of that stuff is like a use or lose, and we know medical's changing constantly. And I like being able to have that knowledge so I can assist in a time of need and being
and
up
that's
on
the purpose and that's the purpose of refreshers, is to, if you know, there are ALS things that I'm required to do but maybe have never done, like a chest decompression. In 13 years as a medic, I've done one. But does that mean that I'm losing it? Well, we still go over it. We still, that's why we do refreshers. That's why we have, updated trainings and things like that, is because there are a lot of things that we don't use on a regular basis. And
Right.
that's where our refreshers and retraining comes in.
Right.
And
I guess I
and
should have asked
the same
too.
for King and everything else.
So I guess I should have asked then, so even me can get those kind of trainers, and especially if they become in advance, where like when we do those, say NCCPs and all that some of you all go through that's more advanced, I know we're allowed to take them. I guess those would be in the, like your respiratories, your resuscitation classes, your RSIs is where we would get those continuing training on like Kings and things, where we get
Sure.
that refresher knowledge.
Could be. And going back to looking for a place that uses King Airway for the basics, right here in front of you, you see the EMT Basic Pre-Hospital Treatment Guidelines, 3rd edition, from the great state of South Dakota. And these skills are the skills that the South Dakota people put out there. And I'm going down to about 70 something, because that's where oral glucose, activated charcoal, that's medication, jump start, SIDS. This is their guidelines for the basic EMT. And I was able to find the King Airway in here, and they allow their EMTs to put down the King Airway. They let them give them aspirin too. There it is, right there. Supraglottic Airways for basic EMTs. Adopted March 2014. So if we're going to come out here and say Arkansas should do it, is Arkansas people in Arkansas any less than people in South Dakota? The answer is no. So if a South Dakota EMT can do it, an Arkansas EMT should be able to do it.
Isn't that based on your medical director?
This is state protocol, and then
State protocol.
Right. This is state protocol from the King Airway. Now, I mean from South Dakota Government of Emergency Services. Now, they may have a statewide emergency medical director, and they may have gone through the research process and then figured out that, hey, they can do it. So here's what I would do if I was really interested in doing this. I'd contact this people right here at the South Dakota Department of Public Safety, the Emergency Medical Service. I might send them go to their link right there, and I would ask them what has been their reported successes using a King Airway by basic EMTs, and they should be able to pull that data up off of their PCRs that they've gotten in. So, and this was pretty interesting. Were developed using the National Traffic Highway Safety Guidelines in reference to assistance with the state of Minnesota and the Commonwealth of Kentucky and PTLS. So I bet you if I went to Kentucky and Minnesota, I would also find the King Airway being used by basic EMTs. So you do literature research. You find out what's going on around you. Did you know there's no basic EMTs in Tennessee? In Tennessee, everybody is either an advanced EMT or a paramedic. That was how they decided to do it. So anyway.
Unless somebody correct me if I'm wrong, I found out our advanced EMTs here for Arkansas, I think there's like a 4-hour or 6-hour difference. And so, it's almost, well, if you're only that shy of a paramedic, why not go paramedic? But some cases I could argue maybe some don't want to be paramedic. They want to be at least advanced to do more and to help and assist their medic. Maybe they don't have the desire to go medic per se. But again, that's just thought on it. I just, you know, for those states that do that, and that's their guidelines and settings, that's great. But at the same time, we're not them states. We're Arkansas.
But wait a minute. If Todd, who is above me right now, is doing King Airway and saving people's life in his area of Newton County, and you're down there in Searcy County and you're not doing it, then why is his people more important than your people? If he could do it, you should be able to do it.
That part I agree. I don't argue that statement. I mean, you're absolutely right. Nobody's patience or cares that they're giving and providing should be any different from the next.
Well, do it this way. Do it this way. We're here in Boone County. I go 33 miles up there to Taney County. Their EMTs can do more up there than they can do down here.
I know. I ain't gonna lie.
It's not right.
I was actually trying to get my license for both places.
Yeah. Todd, anything for the good of the order?
Nothing. I'm kind of a research junkie, though. I like research stuff.
So I can get you to help me with this plan.
Okay.
Oh, Todd's your guy.
Conduct a research project that will allow basics in Arkansas to insert King Airways, right?
That's it.
I'll tell you what, you conduct the data review, and I will be glad to do the literature review for you.
Well, here's what we'll do. Then I'll contact the chairman of the Governor's EMS Advisory Council and get an audience with them to present our idea. Then we'll go out and find a couple of services that'll work with us, and then we'll pull the data together. Then we'll publish. There is an EMS Research Council that meets every January in Minneapolis, Minnesota. Minnesota in January. The only thing you want to do there is stay in the hotel and have your meetings because it's cold up there. But it's run by the UCLA people. That's who does it.
I can desegregate the data and help you with that part of it, as long as you've got the medical side of it down that you're going to present.
Yeah. It'd be interesting. It'd be interesting.
I like your ideas.
Thank you very much. All right. Well, anybody got anything for the good of the order? I see it's 2 o'clock. Let's see, 8, 9, 10, 11, 12, 1, 2. That's 6 hours. I see Regina back in there. We're about ready to dismiss.
I've been listening.
Good deal.
We're gonna stand up and have a closing prayer, and then no, we won't do that. Yeah. All right. Thank y'all for joining.
Okay with that.
Thank you for joining today. I hope you learned something about this, and we look forward to getting here next month with day 2. And then day 3 and day 4, and the basics will be done. Then you paramedics will have 5 and 6, and we'll do those 2. All right?